we are versus arthritis, and we have seen that the impact of arthritis is felt unequivocally across all different sections of society. And you will see in one of the presentations that will be presented later on today, which is the latest report that our colleagues in OHID have launched on health disparities. And in those presentations, without preempting everything that is in the presentation, you'll see that it shows that if you have arthritis, you are more likely to come or live in a deprived area. It also demonstrates that certain groups are more likely to have chronic MSK conditions if you belong to certain minority ethnic groups or if you're a woman. And of course, we need to do a lot in terms of understanding, but also preventing impact on various different groups. And you will see this theme in the presentations today as well. And the one that I mentioned from the OHIDS report specifically asks us to ensure that we identify people at high risk of MSK developing MSK conditions or living with it. It asks to provide support for people of certain minority ethnic groups who are living with that condition, and it asks to report on progress. And all of that is only possible if you have good data and you have good coding. Which brings us to the other part of the afternoon, which is talking about registries. We'll be hearing from a lot of established and new registries and clinical audits today, because it's very important that we are able to measure the impact of any intervention or any healthcare intervention that we are putting in place, to measure it, to see how effective it is, and to learn and to improve it. And you could only do that if you have the data at hand. Now, we at Versus Arthritis believe that it has to, whatever intervention, whatever help, support, or solutions we provide, have to be holistic. And which is why we are Versus Arthritis. We provide research, influencing, we campaign, and we provide services. And we do believe that part of the discussions today will also bring out how we can do all of those better. So without further ado, I would say this is your day. The whole point of these meetings, which I mentioned have been going on for a decade, is to allow engagement and networking. We come here with the spirit of learning and sharing, and see how you might help. You might be able to help others in the field, or actually yourselves take away some of the learnings from the MSK Healthcare field. So thank you once again for your continued engagement. We hope you enjoy the day, despite the temperature in the room. People on Teams will be fine. And I'm sure Michael would say it's an open meeting. I don't know what the etiquette of asking questions and so on and so forth would be throughout the presentations, but we do hope there'll be a lot of engagement and networking during the meeting and during the breaks as well. So thank you very much. I'm going to now hand over to Benjamin Ellis. Benjamin is our Senior Clinical Policy Advisor. We depend on him a lot for advice, but also some of the learning and some of the engagement, some of the networks which Benjamin and colleagues bring to this meeting and this group. So thank you, and over to you, Benjamin.
Thank you so much. Oh gosh, that's very strange hearing my voice in my ear. So welcome everybody again. We are going to start with the first panel is about health inequalities and inequities in musculoskeletal care. Please do put questions in the chat as it goes. You can do that if you're in the room, you can do that if you're at home. We'll hopefully have time for some questions and answers at the end. So the first talk is about equity of access to hip replacement surgery from Stephen Wyatt. Stephen has 20 years experience leading and managing analytical services in the health and social care sector. His most recent analyses have highlighted the scale of inequalities in access to planned hospital services and explored the causes and consequences of these inequalities. So Stephen, over to you.
Oh, you need the microphone, of course.
Yeah.
Good morning, everyone. Thank you for inviting me to talk. My name is Stephen Wyatt. I work for the Strategy Unit. We're an NHS team based in the Midlands. And I'm going to talk about a piece of work we published earlier this year on equity of access to hip replacements and how they changed between 2006 and 2016. It's a piece of work we did with colleagues from the universities of Swansea and Bristol and colleagues from the Royal Orthopaedic Hospital in Birmingham. So first of all, a little bit about equity. I suspect this is something you know very well, but for the sake of one slide, I'll cover it in a little bit of detail. So let's imagine we have a population that we can subdivide into 5 separate populations. Maybe their population is defined by geography, or by ethnicity, or by deprivation. And let's think about the level of need that they might have for a particular health service intervention. Let's imagine it's distributed something like that. So more people in population C with an ability to benefit from that health service intervention than in populations A or E. That may be because of population size, or the age profile of those populations, or the prevalence of certain diseases within those populations. Now let's think that supply might be distributed something like this. So supply levels roughly following the pattern of need. And then in each of the 5 populations, we have the same supply to need ratio. So that would be an equitable distribution of supply. But supply equity doesn't require certain levels of provision. It just requires that the distribution of provision is equitable. So in this second scenario, the same distribution of need, but a much lower level of supply, but nonetheless an equitable distribution of supply. Still the same supply to need ratios across the 5 populations, so that's an equitable distribution of supply. In this third scenario, same distribution of need, but each of the 5 populations receives exactly the same quantity of supply. At face value, that might seem fair, but when you look at supply to need ratios, they're very different. If you live in population A or E and need this service, then you're much more likely to get it than if you live in population C. And the final scenario is another distribution, inequitable distribution of supply. So the principal equity requires that the distribution of a service over a set of populations, subpopulations, should follow the distribution of need for that service over those same populations. So in our particular piece of work, we looked at equity of access to NHS-funded hip replacements. We looked at it over quintiles of deprivation, 5 subpopulations defined by levels of deprivation in the areas they live. We examined it both in England and Wales, and at 6 points in time between 2006 and 2016. Our need data came from the ELSA study. It's a long-standing longitudinal study that tracks a representative group of the population aged over 50 and asks them at various points in time various questions about their health status, including a series of questions about their hip function, from which you can derive something like the opposite hip score. And in terms of supply, we used the hospital episode statistics, which is I'm sure you all know, record level data set of hospital activity, and the equivalent data set, PEGWA, in the Welsh services. So this was the situation in terms of need in 2006. So I'll just tell you how this chart works. So moving from left to right, we move from the most deprived quintile of the population to the least deprived quintile. And what we're showing is, having adjusted for age and sex, what the level of need for hip replacements are across those deciles of deprivation. So people living in the most deprived quintile were about 2.4 times more likely to need a hip replacement than people living in quintile 3, the median quintile, after we've adjusted for age and sex differences across those populations. Meanwhile, people living in the most affluent areas, the least deprived areas, are about 60% less likely to need a hip replacement, having adjusted for age and sex, than their counterparts in quintile 3. So a sharp gradient in need. And if we were to have an equitable distribution of supply, then we would expect that to follow that same pattern, supply levels to follow the same pattern of need. What actually we see is this. So supply levels are actually lower, having adjusted for age and sex, in quintile 1, the most deprived quintile. And the gradient is slightly upwards in the opposite direction. So this is a sort of classic case of the inverse care law. People with the greatest ability to benefit from the intervention are the ones who are least likely to receive it, even in a fully insured system like the NHS. You'll notice that quintile 5, the levels of supply are slightly lower than people in quintile 3, having adjusted for age and sex. But remember, we're measuring NHS-funded hip replacements here, and I suspect many people in that quintile are privately purchasing hip replacements. So that was the situation in 2006, and there's nothing particularly novel about this analysis at this point. Andy Judge did a very similar analysis from the University of Oxford back in 2002 and found very similar results. In fact, his analysis was even more thorough than ours. He explored many alternative hypotheses for this finding and concluded that genuinely it was inequity of access that was the cause. But what's novel about our analysis is that we tracked this same analysis at 6 points in time between 2006 and 2016 to see whether our levels of inequity had improved. So over that period, health policy suggested that we were working hard to reduce health inequalities and healthcare inequities. And you'll notice that that period covers two separate administrations, the Labour administration until roughly 2011 and the Conservative or coalition administration from that point onwards. So just one other piece of information about that time period. So over that period in time, back a little bit, I should have mentioned that one way to think about levels of inequity is about the difference in the gradients of these lines. If these two lines were parallel or overlapping, then we'd suggest it was an equitable distribution. And the further apart the lines are, the greater the inequity. So if the scissors open up, then there's more inequity. If the scissors close, then we would expect less, we would conclude there's less inequity. So just a bit about the context of supply between 2006 and 2016. So levels of supply increased dramatically over that period. In fact, we pretty much doubled levels of hip replacements between 2006 and 2016, NHS-funded hip replacements in England. So there's plenty of opportunity there to resolve this problem. If we, having increased levels of supply, we disproportionately directed some of those, that extra supply towards the most deprived quintiles, we could easily have reduced and eliminated levels of inequity in England. So the potential to resolve this problem was there. We spent the money. All we had to do was direct that care at the people who most needed it, and we could have resolved this problem of inequity. In fact, what happened was that although we increased levels of supply substantially, we didn't tackle inequity at all. Levels of inequity are exactly the same in 2016, and indeed at every point in between than 2006. So big increases in supply, but relative increases were the same in all groups, and we didn't see a substantial change in the levels of inequity. So that's our key finding. Substantial levels of inequity in NHS-funded hip replacements in 2006, and no evidence of improvement in equity by 2016, despite considerable increases in supply levels. And in the paper itself, we talk about, we suggest some more sort of potent policy interventions and operational interventions that we might adopt to try and resolve this problem. This problem has been long-standing. We keep saying we're dealing with it, but the problem doesn't seem to be going away. So we need to do something different if we're going to really address this issue. That's everything from me. This is the reference to the paper if you'd like to read it in more detail. Thank you very much.
Thank you. Thank you, Stephen, and a really fascinating paper and a fascinating presentation. And yes, please get your questions ready. And we'll have lots of questions to ask. For the next talk, we're going to be talking about how ethnicity influences outcomes in early inflammatory arthritis. So equality but not equity. So some of the same themes coming up again. So Mariam, I'm going to hand you the microphone in a second and not walk off with this time. She's a clinical research fellow in rheumatology at King's College Hospital and currently doing a PhD at King's College London. And her main interest is early inflammatory arthritis outcomes. And I just encourage you, microphone as close to your mouth as you can cope with emotionally.
So good morning, everyone, and thank you for the invitation to present my work. And so I will talk mainly about how ethnicity influences outcomes in patients with early inflammatory arthritis, and we published already the paper around May this year. So I have no conflicts. So to overview, rheumatoid arthritis is one of the commonest forms of early inflammatory arthritis, and it has a prevalence of 1% worldwide. The disease is characterized, as we know, by joint inflammation, synovial hyperplasia, and extra-articular systemic manifestations. Without adequate treatment, as we can see in the pictures, the disease can lead to severe joint deformity and disability, affecting the patient quality of life. However, there is a treatment window. So research have found that the early interventions, like in the first 6 months of symptoms, can lead to better outcomes. And here in the graph, we can see the disease severity across time, where interventions or early interventions of the course of the disease can lead to less inflammation and therefore less joint damage. So specifically speaking about patients from ethnic minority backgrounds, they are considered a risk factor for a disease non-response in different diseases, and they report differentials in accessing healthcare services worldwide. So we conducted a study with our main aim is to provide the best information to help clinicians and decision makers to reach the best informed choices about the best management for all our patients and services, and to deliver equity for all our patients. So in this picture, we can see the differences between equality and equity. So equality is delivering the same resources to the same patients regardless the need. However, equity is only achieved when we adapt the resource according to each individual's need. So we looked into, in our study, the variability in the healthcare quality and disease outcomes in patients specifically with early inflammatory arthritis in the UK that are recruited to the National Early Inflammatory Arthritis Audit, or NIA. So NIA is a national audit that was established around 2018 with the main aim is to improve the healthcare quality of people living with inflammatory arthritis in the UK. So we have patient advisory groups in the NIA as well that have different framework roles and advisory roles as well. So NIA is commissioned by HQIP, carried by BSR, King's College Hospital, and Solving. So it is a prospective cohort study design. And the population included adults with a suspected and a confirmed EIA diagnosis, an early inflammatory arthritis diagnosis, in England and Wales. And we subcategorized ethnicities into white, black, Asian, mixed, and other according to the 5 main categories in Census UK. And here in the population diagram, we can see that patient referred with a suspected EIA diagnosis in our study period, which is May 2018 until March 2020, were 36,000. And patients with ethnicity data reported were 35,000. And then when we categorized ethnicities, all as a main group, as a sub group, from an ethnic minority background were 5,000, and patients from white backgrounds were 30,000. And then patients with a confirmed EIA diagnosis were 12,000, and then patients from ethnic minority backgrounds from that group were 1,600, and most of this group were from Asian backgrounds. And then the white patients were 11,000. So our studied outcomes, the first outcome being the healthcare quality, and we addressed that or studied that across the NICE quality metrics. So the first metric 1 being referred from a GP within 3 days of presentation. Metric 2 being assessed in rheumatology services within 3 weeks of referral. And then metric 3 is being or started a DMARD within 6 weeks of referral from the GP. Metric 4, which is offering a self-management and educational materials or activities within 1 month of diagnosis. And then metric 5, having a treatment target set between the clinician and his patient. Metric 6 is delivering advice on how to contact emergency services of rheumatology. So the second study outcome was disease remission, and we studied that using the DAS-28 joint score at 3 months. So the DAS score is a composite score that takes in consideration tender joint count, swollen joint count, inflammatory markers, and the patient visual analogs. And we categorized the disease activity into remission, low, moderate, or high. And for our analysis, we used logistic regression models, and we adjusted for possible confounders, which are age, gender, smoking, comorbidity, serology for the CCP or the rheumatoid factor, which is an indicative of severe disease severity, and the baseline DAS-28. And we took in consideration the clustering between the different trusts as well. So here I can show our results, and compared to white patients, ethnic minority patients were more females with a 71% versus 60%. They were younger. They had a median age of 49 versus 59. They had less smoking exposure, so we had fewer current or ex-smokers from the ethnic minority background. They had less comorbidities as well. However, they were more likely to be seropositive for the CCP or the rheumatoid factor. And their baseline DAS, the median, was not different across the ethnic groups. And also the symptom duration before referral was not different across the 5 ethnic groups as well. And here in this slide and the next, we can show the regression models that studies the association between ethnicity and our studied outcome. So, and here we can see the circles represent the odds ratio and the horizontal line represent the confidence interval. So any result that crosses the 1 is considered insignificant, and right going to better outcome, left going to worse outcome. So when we assess the first metric, which is being referred from a GP within a timely manner, so there were no significant differences across the groups, except for the other group. They were more likely to be referred from a GP. However, we don't know what is the reason behind that result. It might be the small in number, as we can see the wide confidence intervals in this group. And then assessing the second metric, which is being assessed in rheumatology services, there were no differences across group regarding that. And then when we looked into the treatment start across groups as well, there were no significant differences across the white, the patients from the Black backgrounds, Asian, mixed, and other. And then when we looked into metric 4, which is having an education provided, we can see that the mixed group emerged that they were less likely to receive education materials. And that emerged as well for the mixed group and the other group when we assessed having a treatment target set between the clinician and his patient. And that was the same when we assessed the 6th metric, which is accessing emergency rheumatology services. So both the mixed and the other group were less likely to receive that. And here we can think about maybe the language barrier and the limited availability of the non-English language education materials. And then when we looked into the disease remission across the groups, so here we can see in this large cohort from its kind, so patients from Black backgrounds and Asian backgrounds were less likely to be in remission by 3 months. And so patients with Black backgrounds were almost 50% less likely. Patients from Asian backgrounds were almost 20% or 25% less likely. And the mixed group actually had the same pattern of direction of effect. However, they had a wider confidence intervals. And when we grouped the whole ethnic minority as one group, they still were less likely, 20% less likely to be in remission compared to the white patients. So we tried to look at what are the possible drivers of this, and we assessed the initial treatment strategy that were used by 3 months. So patients from ethnic minority backgrounds were less likely to be on methotrexate by 3 months, and they were less likely to be on steroids as well at baseline. So to conclude, fewer ethnic minority patients reached remission by 3 months, and these results could not be explained by the disease severity, the baseline characteristics, the delays in the referral, or the time to treatment. Important limitation to consider that ethnicity was grouped into 5 main categories only, and instead of the 19 categories by the census, and we did not capture any data on treatment adherence as well. So our next steps to tackle this issue is to investigate into the possible drivers of this, reprisal of the management pathways to adapt with the ethnic minority patients, and to value a good communication and a shared decision-making, to involve different patients in this group as well, to have a culturally designed education resources, and to involve the multiple stakeholders to resolve this issue. So here are my acknowledgements. I would like to thank, first of all, the patients, NIA patients, and everyone involved in the team, the sponsors, my supervisors, the rest of the co-authors, and every rheumatology department in England and Wales that participated in NIA. So thank you so much.
Thank you. Perfectly timed. Everybody's perfectly timed this morning. Brilliant. Fascinating and distressing. I think lots and lots and lots of questions hopefully will come in about that, and I don't know how many answers we have yet, but there's certainly a lot there to answer. So Ruth, where's Ruth? Where's Ruth? There you are, Ruth. So Ruth Costello, who's a research fellow at London School of Tropical Medicine and Hygiene, is going to be speaking to us about continuing specialist care to adulthood in young people with juvenile idiopathic arthritis. Ruth is a research fellow at the London School of Hygiene and Tropical Medicine, where she uses electronic health record data to investigate healthcare disruption related to the pandemic, both generally and in people with rheumatoid arthritis. She previously worked at the University of Manchester, where she used electronic health record data in studies of rheumatic diseases. Over to you, Ruth.
Hi, so I'm Ruth. This is my conflicts of interest. So JIA is an inflammatory arthritis with onset prior to age 16, and it's generally managed in specialist care in a hospital setting in the UK. As a proportion of children will go on to achieve drug-free remission in childhood, there's also a proportion that continue to have active disease and require anti-rheumatic medications into adulthood and therefore require specialist care as adults. And this is the group that we were interested in. So estimates of the proportion continue in specialist care as adults varies. Many of the studies are quite old, so over 20 years old, and management has changed over that time. Often studies are based on measures of clinical remission rather than kind of healthcare utilisation. And the proportion continuing specialist care in England is unknown. And this is important because young people transfer from paediatric to adult services by age 18. And this is a time of many changes in the young person's life. So they could be moving from school, college, university, might be starting work, could be moving home. So there's quite a lot going on. And this is acknowledged in the EULAR and PRESS guidance, where they state about the need to manage the condition independently as an adult and address medical, psychosocial, educational and vocational needs. So the aims of our study were to measure how frequently young people with JIA continue specialist care, and then to describe characteristics related to continuing specialist care and using electronic health records in England. So this was a retrospective cohort study. We used data from CPRD. So this is primary care electronic health records, and we used both the GOLD and OREM data combined. And we also linked to HES data, so it's hospital electronic health records, and we used both inpatient and outpatient data. So the inpatient data has ICD-10 codes. The outpatient data doesn't have ICD-10 codes, but it does have the specialist department that they're seen in. And we used the study period 1st of April 2003 to 31st of December 2018. So to be included in the study, we used a kind of validated definition of JIA. So they had to have a read code for JIA in their primary care records, and then either 3 or more outpatient appointments with rheumatology or ophthalmology, or a HES inpatient admission coded with JIA, and both of these had to be prior to age 16. In addition, they need to be registered with their GP beyond age 19 so that we could look at this period of transfer, and then needed linkage to HES and outpatient, and to have outpatient appointments. So this describes follow-up and how we categorise people by continuing specialist care category. So I'm just going to go through the 3 example patients here. So patient 1, you can see they have outpatient appointments throughout their follow-up. They have less than a year between their last outpatient appointment and the end of follow-up. So we categorised them as continuous specialist care beyond age 18, and they were not discharged. Patient 2 has appointments up until just before age 18, and they had more than a year between their last outpatient appointment and end of follow-up. So they were continuing specialist care until 16 to 17 years, and they would be considered discharged. And patient 3 has appointments prior to age 16, so they were discharged prior to age 16. And we used descriptive statistics to describe the proportion continuous specialist care and discharged. We described the time to discharge by age group for incident cases only. And we used multinomial logistic regression to look at the characteristics of patients and how this is associated with continuing specialist care category. So onto the results. So there were 666 young people eligible for this study who had JIA. They were more frequently female, and they had their first JIA code at an older age, so more frequently between 9 and 15 years. So how long did people continue specialist care? So 2 in 10 were discharged prior to age 16. 1 in 10 was continued until 16 to 17 years. And then 2/3 continued specialist care beyond age 18, with about 1/3 being subsequently discharged. And this is the Kaplan-Meier plot of time to discharge by age group. The red line is the youngest age group, so 4 to under 8 years. The green line is the middle age group, so their first JAA code was age 8 to less than 12 years. And the blue line is the oldest age group, so 8, with their first JAA code between 12 and prior to age 16. And you can see that the youngest age group remained in specialist care for longer. So by 12 years, 50% of them were discharged, whereas in the oldest age group, by 7 years, 50% were discharged. And this table shows the characteristics by continuing specialist care category. So I'm just going to highlight a few points in this table. So in terms of age, those continuing specialist care until 16 to 17 years were older compared to the other 2 categories. Those who were female were more likely to remain in specialist care longer. Those who remained under specialist care were less frequently in the most deprived patient category. These are the results from the multinomial logistic regression, and the reference category for this was those who were discharged prior to age 16. And you can see again, so those who were female had higher odds of remaining under specialist care beyond age 18. And if they had comorbid uveitis, they remained under specialist care. And again, you can see those who had less deprivation were more likely to remain under specialist care. And also just to highlight, we looked at the comorbidities. Although there were small numbers, those with depression were less likely to remain under specialist care. So this kind of highlights some potential inequalities here. So maybe those less deprived, maybe those with depression were sort of dropping out of remaining under care. So our results differ slightly from an often cited estimate that JIA will continue into adulthood in 1/3. But our results describe healthcare utilisation over time, and other studies have looked at remission at a single time point, whereas and there's some strengths and limitations to our study. So we used a robust definition of JIA, and this has already been published, the references there. And we use national data, so this is more generalisable compared to sort of tertiary centre data. But there were some limitations, so drug prescribing wasn't available because this is mainly done in secondary care, and this information is not available for secondary care prescribing. And we also don't have information on ILAR subtype, as this just isn't coded in the primary care records. So in summary, 2/3 of patients will continue specialist care beyond age 18, with 1/3 of those being subsequently discharged. Female gender, less deprivation and uveitis was associated with remaining under specialist care. And these are previously unknown estimates, and they're important for young people with JIA and their families, so they can know what to expect. And also for clinicians running, developing and planning their young adult services. I just want to acknowledge my co-authors and the funders. And also this is the QR code because the paper has now been published. Thank you.
Thanks. Would you want to stay around? And can I Mariam and Stephen as well, just sort of to approach generally, and we'll have some questions. Hang on. We're not
Still got 2 more presentations.
Oh, we've got 2 more presentations. I thought it was. Oh, no, please stay sitting. Oh, hang on. I've got to turn over. 2 more presentations. Excellent. Athena. So Athena is our Senior Public Health Intelligence Analyst at OHID, Office of Healthcare Health Improvement and Disparities. And she's on a secondment from Versus Arthritis, or for Versus Arthritis. Her main pieces of work include producing the musculoskeletal conditions profile on fingertips and the new musculoskeletal health trends, risk factors and disparities in England tool. Athena, over to you.
Thank you. So hi, I'm Athena. I'm a data analyst working in OHID in the Population Health Analysis team. My role is currently funded by Versus Arthritis. The Population Health Analysis team leads on the analysis and monitoring of non-communicable diseases, risk factors and wider determinants of health. In previous years, the main sort of aim of my role was to try and create a platform for local MSK data, which we've achieved via the Musculoskeletal Conditions Fingertips profile. We presented this at a previous meeting, but if you haven't seen it already, then please do go over to Fingertips and have a look. One of the biggest drawbacks we found with this at the moment is that we're limited to the amount of national data that we can put on Fingertips. It is set up for local data. But a lot of the data around inequalities is better at national level because at a local level it produced just too small numbers. So for this reason, this week we have published the Musculoskeletal Health Trends, Risk Factors and Disparities in England. It has a selection of national level indicators which have enabled us to have a deeper look at different inequalities and MSK prevalence. The link's available on the screen, and I think Michael's also sharing it in the chat. So do go and have a look at it as I'm talking, because it's got lots of information on there which I can't cover in 10 minutes. We're hoping that as we build the tool into the future, that we're able to add more data onto it. At the moment, it is just a first draft, and we only have data from Health Survey for England on there. So as a quick overview of the tool, we've got a key messages and introduction section, and then it moves on to a prevalence section where at the moment we've got musculoskeletal conditions, arthritis and fibromyalgia, back, spine and neck pain and chronic pain, which is then broken down into the inequalities on the slide, which are age, sex, ethnicity and deprivation where possible. Then it moves on to a risk factors section, which covers each of the 4 conditions above by obesity and physical activity. So as a quick overview of the prevalence section, for those of you not familiar with Health Survey for England, it's an annual survey of about 8,000 adults, and each year a different set of questions are answered. 2018 was the last occasion that questions on MSK were covered. And the trend suggests that long-term MSK conditions are rising from 15.4% in 2015 to 17.1% in 2018. In terms of age and sex, you can see from the shape of the graph that long-term MSK prevalence increases with age from 4.7% in those 16 to 24-year-olds reporting a long-term MSK condition, up to 39.7% in the 85-plus category. Women reported a higher prevalence of long-term MSK than men, which becomes particularly evident around the 45 to 54-year group. You can see in that age group that the confidence intervals are no longer overlapping for men and women, and this continues as you go up the ages. The ethnicity data is quite interesting. You can see that the Pakistani group has a significantly higher prevalence than the England average at 20.8%, and that the Chinese group at 7.4% and the other white backgrounds group at 13.3% were significantly lower. We were able to break this data down into men and women, and you can see from the charts that it's Pakistani women driving the high prevalence. That group had a prevalence of 29.1% compared to the men group, which had a prevalence of 12.9%. We then got deprivation. So prevalence of MSK conditions also varied by deprivation. Those in the most deprived quintile showed a higher prevalence of long-term MSK conditions at 21.8%, compared to the least deprived group at 14.4%. You can see by looking at the red-coloured bars that there's a steady increase in MSK prevalence with each drop in deprivation quintile. When breaking down further into men and women, there's a clear gender disparity between women in the most deprived quintile having a 9.5% higher prevalence than those in the least deprived quintile, compared to men who had a 5.4% difference between the most and least deprived quintile. So it is women in the most deprived group where it might be a good idea to focus some resource on. We were able to break down MSK into two different categories. So the first was arthritis and fibromyalgia, which showed a similar pattern in terms of deprivation, with higher rates in the most and second most deprived quintiles, and again, that greater disparity between women and men. The back, spine and neck pain category was slightly different. You can see the confidence intervals are a lot wider, and although there is a significant difference between the most and least deprived quintiles, the deprivation deciles in between were similar. Men and women also had a similar prevalence, which again you can see the confidence intervals overlapping for men and women in this chart. We then go on to look at the risk factors section of the report. So this data hasn't been published before and it's a new official statistic. The chart speaks for itself really. Being a healthy weight had a significantly lower long-term MSK prevalence at 12.7%. And each increase in weight led to a higher prevalence of MSK up to 28.9% in the obese class 3 group. Being underweight also showed a higher MSK prevalence at 24.6%. For arthritis and fibromyalgia, the obese class 3 group was the only weight category to have a higher prevalence than the England average at 14.5%. And this is a slide that I think is quite interesting. For back pain, it was being underweight that led to a higher MSK prevalence of 10.2%, and being overweight and obese groupings all had similar prevalences to the England average. We then go on to look at physical activity data. So 2018 was the last time that MSK questions were asked in Health Survey for England. And they also asked a question on physical activity based on MVPA, which is moderate or vigorous physical activity. And survey participants could answer either more than 30 minutes or less than 30 minutes. It's worth noting that physical activity recommendations are to do over 150 minutes per week. But as the chart shows, even doing 13 minutes of MVPA activity can cause a significant reduction in MSK prevalence, with 14% reporting a long-term MSK condition in the more than 30 minutes group compared to 25.6% in the less than 30 minutes group. Similar results were seen for arthritis and fibromyalgia and back, spine and neck pain. It suggests even doing a small amount of physical activity is better for your MSK health than none. But obviously with both obesity and physical activity, it's difficult to tell if it's the risk factor leading to the higher MSK prevalence or the higher MSK prevalence leading to the reduction in physical activity or obesity. So further updates to the tool are that should say 2021 data for Health Survey for England comes up next week. So we're hoping to get some more up-to-date data in there. We're hoping to add a section on employment and musculoskeletal prevalence, as well as a section on quality of life and musculoskeletal prevalence. And if you have any data that you think might be suitable for this tool or for our local fingertips tool, then my email address is there on the screen, and I'm sure Michael will send that round. So do get in touch. Thank you.
Thank you for the presentation, and the report was fascinating reading as well. And the slides all will be shared. The link to the report is in the Teams, I think, as well. And I think some of the data, particularly underweight, I think asked some really interesting questions about what we're not capturing in the data, comorbidities and other things. But hopefully this will come out in the questioning. I think it's hugely interesting. Thank you. Finally, we have Sue Brown from ARMA, who is going to present. I can see you, Sue. So Sue's presenting online and not using slides. So can we remove the slides, Michael, and get Sue onto the main screen? And Sue, I think all of us will know, Sue is the Chief Executive of the Arthritis and Musculoskeletal Alliance, ARMA, which is an umbrella body representing the breadth of musculoskeletal conditions and professions. ARMA has a vision that the MSK health of the population is promoted throughout life, and that everyone with MSK conditions receives appropriate, high-quality interventions to promote their health and well-being in a timely manner. Sue, over to you.
Brilliant. Thank you very much. Not so much presenting as giving you a very brief heads up about something that we are going to be launching in the new year. So thank you very much to Versus Arthritis for giving me the chance to just raise this with an audience that I think is very relevant. So in the new year, we will be launching an inquiry into musculoskeletal health and inequalities. It's a very complex area, so to make it actually possible to do something useful with this, we will be focusing on deprivation, because we've seen today from the data that this is a significant driver of MSK health inequalities. And our aim is to try to move the discussion from look at the evidence of the inequalities to what might we be able to do about it. So we will be launching a call for evidence, a call for submissions, and we're going to be interested from the research community. We're going to be interested in any evidence that adds to our understanding of the issues, particularly evidence of any differences in access to services, and particularly anything which points to the underlying causes of the inequalities, because we think that is something that is important if we're actually going to be able to do anything about it. We're also going to be interested in any submissions from local services that have done anything to attempt to address these issues. We'd be interested to know what you've done, why you did that, and any evidence you have about effectiveness or otherwise. And parallel to this, we will have an exercise in gathering evidence from lived experience as well. So it's really just to give you a heads up that this is coming. We hope that you will all engage with it, and I'll pop my email address in the chat so that if anybody wants to catch up with me about it afterwards, then please feel free to get in touch. And thank you very much for the opportunity to just introduce this briefly.
Thank you, Sue. I'm going to leave you. You're on the big screen in the room. I'm going to leave you on the big screen, and now we do, in fact, actually have the questions and answers bit. Oh, I've left my laptop over there. So I was going to start with, really nodding very well this morning. So we've got some questions that have come in through the chat. So why don't we start with those? And Stephen, there were a couple of questions to you. Just scrolling up. Hang on, I'm seeing messages. We can't hear you now. Okay, so Stephen, we had a question. This is from Rosanna. So is that, I'm just going to read out exactly, there might be the odd word missing. Is more recent data showing the same trends where COVID will have had an impact on overall rates of surgical provision? Do you want to come up? I think well, yeah, maybe we can have conversation between panelists as well.
So we do have more recent data on supply levels and inequity in supply, but less so on the need data, which is a bit of a lag because ELSA takes a while for ELSA data to become available. But the information that we have on supply levels suggests that during the pandemic, we substantially reduced access to elective care. We know that. It was a deliberate intention of the health service to free up capacity for COVID patients. But as we did so, we cut back on care inequitably, further increasing levels of inequity that were there before. So we cut back substantially on provision, but we cut back harder actually for people living in more deprived areas. The people got through to elective treatment in those few months after COVID, and in the months beyond that were more likely to be people from more affluent areas. So unfortunately, the evidence suggests that during COVID, we actually made matters even worse than I was presenting here today. I don't suspect levels of need change substantially over the short term, so I think the patterns of need probably were about the same as before.
And not for the first time, inequity and inequality rose during a public health crisis. And it's interesting, Sue, just asking you to reflect on that. It's interesting, the rising inequality in waiting times doesn't seem to be part of the national conversation. There's lots of conversation about waiting times, but the inequality part seems to have dropped out. Would you agree?
I think, apart with some notable exceptions, yes, absolutely. And I think there's also a tension between these two things. If you want to get that waiting list down as fast as possible, you want to do the easiest people, the people who are most prepared for surgery, the people who have no complexities in their life. So I think there's almost if you focus just on getting that waiting list down, you almost drive things in the direction of inequity.
And if we're using a lot of private sector provision, that's generally available in areas of less deprivation.
Yes, and also if you're asking people to travel and enabling people to travel further than you might normally, again, it's the people who can travel easiest, the people who don't have issues with childcare and carer support, and how do they travel? So everything about this, if we're not careful, is driving things in the wrong direction in relation to equity.
Thanks, Sue. And another question, Stephen, for you, another technical question. So has there been any data in the last 5 years on the hip replacement NHS equality? Two hypotheses: that in the late 2010s, more people used private healthcare, but since 2021, and the growing issues with living cost is reducing that as an option. I think I understand the question.
I think that's a very similar question to the previous one, which I think I've probably picked up. Maybe one other piece of information that I didn't share during the presentation. So there's another piece of work that we've done which tries to explore where on the pathway these inequities in access to hip replacements emerge. Is it that we're not picking up cases early enough in the early parts of the pathway, or we're not referring people early enough into secondary care? And that analysis suggests that the inequities tend to emerge quite late in the pathway, after patients have been referred into secondary care, which suggests that if we're going to solve the problem, that's the point at which we need to try and tackle the problem. We need to think about why it is that, having been referred to a specialist, some patients are going through to treatment and for hip replacements at greater rates than others. And I think to come back to Sue's point, we need to think about the wider factors that might impact on a patient making a decision to go through for hip surgery. And it's things like care responsibilities, travel costs, disruption to employment that they maybe couldn't afford, maybe about lower expectations of health as well amongst those populations. Those are probably where the solutions lie to this problem, rather than thinking about it being an upstream issue. I think patients are being referred at the right levels, but not receiving treatment at the right level.
That's fascinating, and sort of on one level, and Mariam, I want to bring you in here because I think this links to your presentation, that on one level we live in an unequal society, an inequitable society, and that's sort of the reason underlying it all. But then there's something about thinking about your presentation. What do you have any hypotheses about, in the same way Stephen was saying, where the problem is beyond discrimination or inequitable treatment in general? And what are the potential, I think, Stephen, a question for you as well, what are the potentials for doing, I hate the word deep dives, but let's say detailed analyses or qualitative research to actually understand what the policy solutions might be, other than radically transforming society, which might not just be possible in the next 5 to 10 years? That's a sort of general policy-ish question. We also have a technical question for you as well, but I'd really interested to hear your thoughts on that.
As a clinician, when I am like kind of encounter with an ethnic minority patient, as being an ethnic minority, me and myself, so patients tend to have negative beliefs about the treatments of rheumatological issues. So they tend not to adhere to the medication and they are unwilling to start on the medication. So I think if we work more in establishing the best or effective rapport between the clinician and the patient, that will help more in the and trying to keep the patient on the optimum treatment for his condition. This is one of the issues.
It's interesting that in certainly some of the work that was published in the last year on treatment of pain in Black people, it showed that and also childbirth, increased morbidity and mortality, that disappears when the care provider is from the same heritage, minority, ethnic background as the person themselves. So yeah, and you wonder if that, I don't know how you could do that from NIA. I don't think you could. We don't capture ethnicity of clinician, do we? Maybe we should. Maybe we shouldn't. There was a specific question. So Joe's asked, can I just check whether this was based solely on the RA patients in NIA or all cohorts? And Joe's asking from NAS, so wondering if it's applicable to axial SPA patients who we struggle to get engagement across all ethnicities historically.
We restricted the analysis to patients with rheumatoid arthritis. But we have patients with ankylosing spondylitis, but we did not do the same analysis to them. But the majority of our cohort had rheumatoid arthritis, so they are quite representative of the group. So if we found it in rheumatoid, it might be the same thing in other diseases, but it's an assumption only about the other group of patients.
Great, thank you. I'm sure that, well, there may be more questions, but there was some questions for Athena in the chat as well. So Athena, in the figures where you report comparisons between men and women, was this just for adults or were children included in this data too?
So all of the data is age 16 plus, so just for adults.
And then another question about the physical activity aspect generally. A clarification, is this activity levels before people developed a musculoskeletal condition rather than levels while living with arthritis, brackets, or a musculoskeletal condition?
It's survey data, so it's one point in time, so you don't know which way round it is. So you don't know when they've developed the musculoskeletal condition, you don't know if they've got a musculoskeletal condition and that's why they're not doing physical activity, or if they've always had low levels of physical activity and that's developed into a musculoskeletal condition. So it's just a limitation with using survey data.
Can I ask you, I mean, when I read the report, a few things stood out. I mentioned some questions about the underweight data, which is really unexpected, that chronic pain overall, you don't see an increased prevalence among people who fit into an underweight category, but you do see it for back pain and I think musculoskeletal pain generally. That really stuck out for me and thought, well, that needs some more. I'm not quite sure what's going on there. What stuck out for you as surprising, or, I mean, others we've talked about deep dives, more research to try and understand questions. What emerged for you as either surprising or really in need of more investigation?
I mean, the back pain and underweight was the biggest shock, that I wasn't expecting that result to come out, particularly because I assumed that obesity and being overweight contributed to back pain, and that wasn't what it showed. And then the ethnicity data as well, because previous data sets that we've looked at have always shown Black Caribbean people to be the group that really stands out with high MSK prevalence. Whereas this time we were able to look into that Asian group in a bit more detail, and that Pakistani women group, it's always been hidden when we've looked at other data sets because it's in that overall Asian category. And then when you are able to look at that level of detail, it really stands out as a specific group that do need some extra support.
Yeah, it's interesting, isn't it? So the Health Foundation report that was published last year, time has all become incomprehensible since COVID, but published recently, identified people from Pakistani and Bangladeshi heritage very specifically at higher risk of chronic pain, although they didn't pick up the intersection between being a woman and the heritage in that case. So that's not entirely surprising. But when we looked, often Asian, in inverted commas, gets grouped together because of small numbers. And what you showed, and that the Health Foundation report showed as well, was that among people from Chinese heritage, actually very, very low levels of chronic pain and musculoskeletal problems. So actually there's a risk to lumping large groups of people together simply because they're a minority and simply because their heritage is from somewhere other than right here.
Exactly, and the deprivation data is quite interesting as well, seeing that gender disparity between men and women in that most deprived group, because you would assume that heading towards between the deprivation deciles, that men and women would be consistent in the gap between, but seeing women go such a bigger difference than men in that deprived group was quite interesting as well.
Thank you. Yeah, it doesn't make it any less shocking to see it again. Any questions from within the room? Yeah.
Hi, a question for Mariam actually, but more of a comment. We had a recent event with for Asian patients with rheumatoid arthritis, and one of the key things that struck all of us was a comment from a lady who is a litigator, very bright, intelligent Asian lady, and it was around the adherence. She said, I know intellectually and intelligently I need to take the medication, but emotionally and culturally, I have a real barrier. And it was the family around her as well, taking, inverted commas, Western medicine. And I think there's a big hurdle to overcome in how we communicate and educate and get that patient education to the various different Asian communities on not looking at it as Western medicine. And I think that's where patient organisations like ourselves, a little plug for NRAS, with our Acme Jung section on the website in Hindi and Punjabi, to really change that perception.
Thank you. There's some other questions. Do you want to come back on that, Mariam, or we can take some more points? You need a microphone.
Studies showed that patients from ethnic minority backgrounds tend to have the negative beliefs about the medication. So culturally, or like either like implementation by what they believe about the immunosuppressive or the mechanism of the medication itself. So I think that is a major issue, yeah.
We can take two questions at the same time, and then we'll get them both. I'm over this end, so I'll come to you first. No, you will, because otherwise the people at home won't be able to hear. Or not necessarily at home, but the people who are not in the room. You need to hold it quite close to you.
Actually, the question is for this lady here, in mustard top. Can you specify, when you say Asian, can you specify which groups in the Asian community, please?
Okay, yes, let me come back to you. Yeah, Claire?
Yes, this was specifically focusing on the South Asian population, so India, Pakistan areas, but we know that's a real catch-all term saying, and I think that was what was just picked up a few minutes ago. I think we need to be very more specific about that.
Just say one thing, if it's South Asians from India, from East Africa, there is a big difference. From Africa, there's no problems there at all on taking when I want to explain.
Thank you. And just if you didn't catch that at home, there was a bit of a discussion in the room about there are Indians whose families have come here directly from India, and people that came via East Africa, and differences in health beliefs, and that people coming from East Africa might have health beliefs which are closer to Western models. It's fascinating, and I think somebody in the chat's put an interesting, the tyranny of aggregate data, but it's not just the tyranny of aggregate data, it's also the tyranny of aggregate preconceptions, groupings in more general terms. I'm aware that we're handing around a microphone, and not everybody might be comfortable holding a microphone that 4,000 people have just held. So just let me know if you want me to hold it when you're speaking, and there's lots of hand sanitizer around as well.
Thanks, Ben. I'll hold if that's right. So 2 questions. One is for Athena. I think there's an inequality of diseases as well. So I carry the flag for fractures. Fractures of the hip are the 2nd most common cause for emergency bed day admissions in the NHS, and probably the most preventable. And I was really surprised to see that in your first phase you haven't included osteoporosis. So that was just a comment, because there's lots of data available for that. So to have that feedback. And then a question for Stephen. You've done an assessment of need versus delivery. And I'm not up to date in the OA literature, but I seem to remember there's lots of literature that people from ethnic minorities and deprived groups have worse outcomes after replacement. So actually their risk benefit for surgery is different to someone who's privileged. How do you even go about accounting for the fact that if you have a hip replacement and you're deprived, your benefit from surgery is probably going to be different than if you're privileged and have a replacement? Because that will alter your graph of need versus delivery.
Two fascinating questions, and while I'm walking over, that makes me think about some of the work we've been doing with NHS England on decision support tools, and whose data goes to supply a decision support tool, whose risk, whose benefit, and how do we personalise those for people from different situations? And the scandal, can you imagine if you did? But yet it's really needed. Right, who am I coming to? I'm coming to Athena.
So we put Health Survey for England data in there, just a decision that was a big data set and that doesn't break down into osteoporosis. So in the future, we are going to look at other data sources to get in there. So hopefully we'll get that in there then.
One of the things with Health Survey for England is that, so the chronic pain module that went in 2017, everybody had to do, but normally it asks you, do you have a long-lasting condition, which is defined as a condition of 12 months or more, and an awful lot of people don't consider their back pain or their osteoporosis. And they'll put their diabetes, they'll put their COPD, but it's what people happen to contribute. And in the survey instructions, I think the person asking the question is instructed to say anything else, anything else, anything else, until the person stops talking or hits them. So, but it doesn't say, do you have a musculoskeletal condition? Do you have? So I think a lot of conditions can be quite invisible in Health Survey England, which is one of the reasons we funded the chronic pain data. Stephen, question for you about differences in outcomes.
I'm not going to answer your question, I'm afraid. but yes, just to confirm my understanding as well, same as yours, that people from deprived areas, having adjusted for their hip function at baseline, age and sex, etc., have poorer outcomes after hip replacement surgery than people living in more affluent areas. And I suppose I'm not going to answer your question because I don't know the answer to the question, but I think one of the things that I've been worrying recently about this idea of outcomes-based contracts for hip replacements. If you start paying providers based on the outcomes they achieve for people from their hip replacement, and you don't recognise that inequity, then you have a risk of building in a disincentive for providers to work with people from deprived areas or other people that don't necessarily get good outcomes. And the reason they don't get good outcomes is probably not to do with the quality of the surgery or anything like that. It's probably to do with the quality of the aftercare, which the acute provider doesn't have much influence over. So I don't have an answer to your question, but I worry about the same thing.
Thank you. I mean, I'd be really interested if people have thoughts either online or in the room about how some of this could be addressed or thought about in policy terms, or starting the conversation which is going to go towards Arma's reports. If anybody wants to offer a suggestion or a thought, very welcome. Any other questions in the room or online? Yeah. Oh, there's a couple of questions online now come across. Good. So Neil saying, which outcomes are worse? So question of Cassim, is this post-operative health score or the health gain between pre and post?
I think the two are linked.
We think the two are linked.
Yeah. So.
I think that the two are linked. If you have a lower post-operative health score, then your gain will be smaller, and it's what Amit Kiran said. It's the proportion of achievable gain that you've achieved. So if you're really high up, how much have you got better? But I think it's a real issue because you may be hammering the provider when actually it's a deeper issue, and actually just putting more money for more surgeons isn't the way to improve outcomes. It will make you focus on the areas because they do need more investment, but how you implement that to really achieve your outcomes for that population is a lot more nuanced. And as you said, you might actually perversely make it worse. And then the minister will say, well, I've given you $1 million and the outcomes are worse. I'm not going to give you another $1 million next year. And that would be a sad outcome, really.
So this makes me think two things. First is that it'd be great to hear a presentation at a future event from National Joint Registry folks actually looking at that exact question, because it's a question we haven't answered in the room. And so I'd be really, is it about health gain? What do we see with inequalities? Is it about people gain but not as much? So I think that's a really interesting question. And then I think the question, and Devon said in the chat, and then there's a hand up here, but there's a comment in the chat, is this about MSK provision in poor areas impacting on outcomes? It could be. I wonder, be interested in people's thoughts, but also it's wider. It's the stuff I think Sue was talking about. This is about people's whole life circumstances and people's ability to engage in rehabilitation, not to mention other stresses that people have, people's ability to take time off work, people's ability to not have to be caring for others, and so on. So I think it's probably much wider, and I think a mistake might be to just say, well, what we just need is more physio in the pathway, and actually it's probably quite deep-seated, and like a number of things we've talked about here, you sort of think, well, actually this is going to need some good case studies and maybe some really quite detailed analyses followed by pilots to try and unpick. Did you want to come in, James? And then there's a few more questions online.
Yeah, it's really interesting, the conversation about this. Just to come back to the point about hip fractures, if you're from a more deprived area, your outcomes are not as good. And it's really hard. And I was thinking about the analogy with hypertension, and do you use ACE inhibitors to treat hypertension in black people? And for years we didn't. The evidence base underpinning that actually was not convincing, and the guidelines are now slowly shifting to say that you shouldn't not use that class of drug. The reason that supposition started was that in the trials, black people did less well in the trials than non-black, than the white populations. But they did less well for many reasons. It wasn't because the drug or the intervention was less effective, it was all the other things. And I worry that sometimes if we look at deprivation like that, you have this problem that the reason that people who are deprived do less well is not because the intervention is less effective. It's because of the comorbidity, the socioeconomic factors outside of that. And that makes it really tough to then say, well, should you weight the value of the intervention differently?
It's a great point, but at least perhaps we could be talking to people about what they can expect to gain from their surgery if it's likely to be different, and then they can make an informed choice for themselves. But it raises some really, really powerful and uncomfortable questions. I can't be the only person at the moment feeling deeply uncomfortable. Ailsa is on the line. Ailsa, we're just going to put you on the screen and on the spot because you've asked to come in. Welcome, Ailsa. Brilliant to see you here. Thank you.
Hello. Thanks, Benjamin.
You wanted to share something.
Yeah, just briefly. We've recently, with Shirish Dubey in Oxford, we did a panel sort of interview with myself, Kanta Kumar, and Adi Adibajo on health inequalities, specifically taking the data from the NEAR audit, which Mariam has presented on, and looking at potentially why those differences are there in a room full of it's to do some online training for doctors in training and to try and get them to think about these health inequalities and unconscious bias and all of that sort of thing. It's in the process of being edited at the moment, but the plan is to use that online and just get people thinking about how they might approach consultations differently and make them more individualized for ethnic groups, particularly in regard to things like the medication adherence and all of that sort of thing that we've heard about already. So I just wanted to flag that. But I think it's some of these questions that we're talking about this morning are very complex, and there are no easy, one size fits all solutions.
Thank you, Elsa, for sharing that. And actually, there's probably, in addition to that, I suspect there are a number of places and projects around the UK and perhaps wider that perhaps, Sue, as part of the work, we can help capture. Because, yes, we want to expose the stories and the problems, but also we want to be able to tell of where people are trying to make a difference and where there's been success. So I think, Elsa, thank you for sharing that, and I think clearly a lot more is needed. Patricia, you had a question. Do you want to ask it out loud?
Thank you. Hi, Sue. It's a question for myself. It's just in relation to the inquiry, the ARMA Health Inequalities and Inquiry. How will you seek the views of people living in more deprived areas from those in... oh, you've answered it. So I appreciate the inquiries from members, but it'd be worth maybe advertising with community groups and with groups we know that have MSK conditions identified in the OHID report. Be happy to help with that and identifying groups and things like that. So seeking views.
Yeah, so could you say, not everybody, I think most people in the room aren't reading the chat, so do you, although I am, do you want to just say what you said in the chat as well?
Yeah, so I think this is probably the most challenging bit of the inquiry, is how we make sure that some of our lived experience work evidences from those relevant communities, and it's very challenging. So I think we're going to be needing to look at several ways of doing this, and one thing we're considering is having some sort of pack that enables a group to facilitate a conversation and then send the write-up of that conversation in. So we're hoping that the ARMA member organisations that have groups in relevant areas will do that, but also organisations that are not necessarily involved in musculoskeletal health, but work with groups of people who will be in this group, will also do that, so that we get a really rich evidence from lived experience as well.
Thanks, Sue. I'm just looking in the chat and I can't see anything there. Oh, yeah, sorry, you did put your hand up before and I ignored you.
Thanks very much. It's a question for Ruth. So this week, the new NHS data on young people living with, rates of a probable mental disorder rose from 1 in 10 in 2017 for 17 to 19-year-old young people to 1 in 4. And just thinking about your research findings that young people with depression were less likely to stay in specialist care, and that link with long-term health condition to mental health. Were there any thoughts from the research team on the challenges, barriers, but also opportunities around that?
Yeah, so what was it, the challenges and barriers? Yeah, sorry. I guess just identifying and making sure that trying to keep in contact with these young people is important, and just trying to keep following them up. I guess would be the way to try and keep them engaged with, and trying to have a good rapport maybe with building up a good kind of relationship between the patient and the clinicians might help with that, which we kind of assumed with the younger group that remained under specialist care. We thought maybe that they were getting a good kind of relationship and remaining under specialist care. So maybe people with depression, if you know that, then maybe trying to build that up would be.
Thanks. I think one last word to Claire. Last question.
On the data that you've looked at, young people staying in care continuously, often what we're hearing is when children go into remission, so they're discharged, but then into early adulthood, the symptoms may come back, and then they're often recategorized as RA or PSA or AS. how can we address that? Because really it could be linked back to their JIA diagnosis from a child.
Yeah, I think you're right about that diagnosis issue. I think with our data, hopefully we didn't see there were people with gaps in care, and we did kind of report that in the paper. They should get captured. They might have a code for RA, but they would get initially picked up as like with the JIA, so it should be captured within our data, but I know that's an issue, and we did, if in the paper it does describe kind of gaps, I think, so it could be worth having a look.
Thank you. Well, I think we're going to head for a break for 20 minutes. So we'll start back at 11:20. I've taken from this morning some messages that perhaps in thinking or discussing very often that we need more resources and more quality for everybody, it's really easy to lose sight of groups who, as we saw in Stephen's data, that just adding resources doesn't reduce the inequality. And that's an important thing to realise as well, that there are underserved groups across, I think, every domain we looked at, and it's not immediately obvious always why or what needs to be done beyond the obvious that we live in an unequal, inequitable society. That doesn't necessarily help us identify in our inability to change the whole of society, well, what can we do that would be effective? And that some of that may lie outside of the direct health sphere, and we may need to be thinking more about the wider issues and the wider support. And also in communication, do we have the data to be able to tell people in a personalised way what their outcomes are likely to be? And how does that then work at population level if we're funding by outcomes? And what does that mean? Because if your outcomes are likely to be less good because of circumstances outside of your control, then we're penalising services potentially in some of the most deprived and needful areas. So I think I'm left with more questions than answers and a deep desire to see some good qualitative research and deep dive numerical research. And I would love to be able to hear more about that at future meetings. Is there anything else? Announcement from Michael.
Thanks, Benjamin. And thank you to the speakers. Two quick comments before we wrap up for break. One is just on your point about the NGO coming to present. They are presenting, they're on the first presentation of the next panel, not specifically on the questions that we've raised. And if the questions are asked, he might be surprised because I think he's joined the call yet. It's more generally about the registry, but I'm sure we can bring it up. And the second point was, it might be a bit of a call to arms, just on the back of the question to Athena about children in a health survey for England. So we don't have a great deal of data on children with MSK conditions in South England. In the last 3 years, DHSC have flirted with the idea of funding a boosted sample in Health for England, but at the last minute it's been pulled each time. And now we've been told again that they're thinking of funding it next year. And I think what we'd like to do, potentially, this time is not so much get a consortium together, maybe a consortium is a bit too much of an official word, but get a few like-minded people together, I think with myself and Lynn in the room, who's our head of Children and Young People Services, and maybe just lean on them ever so slightly and say, look, this is a good idea to boost sample for children, and get some of the questions that we might be interested in including in the next survey for England. And that would likely be the 2024 version, so it'll have to be finalised next year. But yes, if you are interested in that and you would like to join our call of arms and lean on DHC, then please do get in touch with me. I'm going to make a slightly controversial, maybe executive decision. Because the conversation is so lively, let's take a 30-minute break and then we'll reconvene at 11:30. Thank you. Hello, everyone. Welcome back. So we'll get straight on to the second panel, and I'll introduce you to your chair, Patricia Stapleton, who's our Senior Policy Manager.
Hi, everyone. The next panel is called Musculoskeletal Clinical Audits and Databases, Successes and Learnings. So our first speaker is Chris Bolton. Chris is online, he isn't with us, but he'll present online. So Chris is the Deputy Director of Operations at the National Joint Registry. So Chris Bolt has been working in clinical audit for 20 years and is an experienced leader of national clinical audits and registries in orthopaedics. He previously managed the National Hip Fracture Database and the Falls and Fragility Fracture Audit Programme. He's now Deputy Director of Operations for the National Joint Registry, leading work streams related to reporting of data, data quality, medical devices, and research using registry data. So I'll hand over to Chris, if you're ready to go and you want to share your screen.
Brilliant, thank you very much. Can everyone hear me okay?
Yeah.
Super. Okay, thank you for inviting me to speak. My name is Chris Bolton. I'm Deputy Director of Operations for the National Joint Registry, and I'm just going to give you a whistle-stop tour of the last 20 years of what we've been doing in the NJR. I'm probably going to focus a bit more on the exciting stuff that we're doing now, but there's a lot of legacy here, so I'll try and cover it all in the next 10 minutes or so. So the background to the NJR is that in 2002 there was a report into widespread failings of the 3M capital hip, and what became apparent there is that there wasn't really a robust mechanism for identifying which implants had been put into patients, at least not centrally, and there wasn't really a robust mechanism to be able to surveil the performance of devices used in joint replacement surgery to try and pick up the signals of failure earlier. And so the NJR was born. We started collecting data in April 2003 for hip and knee replacements in England and Wales. And subsequently, we've evolved to include other joints. So we now collect shoulders, ankles, and elbows, and other geographical locations in the UK. So NJR is the largest database of its kind anywhere in the world, although one of the American registries is fast catching up with us in terms of numbers. There's around 3.7 million records on the registry, and we accumulate a further 250,000 cases every year. So what's our vision? Well, we consider ourselves to be the exemplar of a joint registry. We want to remain focused on the patient and how we improve safety for the patient. But we also want to inspire the communities of registries around the world to try and lead the way, try and show what we can do at the cutting edge of analytics. We also are very clear that research is very much a part of what we do, both in providing data to support research by others, but also in terms of conducting research ourselves. And so that's part of our program of work. So mission of the NJR is here. I'm not going to read it out, but essentially we want to collect and analyze data. We want it to be good data, and we want that data to be focused on improving safety and outcomes for patients. We work with a whole range of stakeholders across the piece, and our role in that is in making sure that the policymakers have the right data to support decision making, that we're listening to the views of our stakeholders in terms of what data we're collecting and how we're analysing it. So we're very much see ourselves at the centre of the joint replacement infrastructure within the UK and indeed internationally. So just a bit about how we're set up. So the NJR is owned by NHS England, and we are hosted by the Healthcare Quality Improvement Partnership. So HQIP provide us with a number of services. They also provide us with legal entity status so that they hold our contracts for us. The business end of the NJR, if you like, is overseen by the steering committee, which is an NHS England expert committee, and that's chaired by Professor Sir Paul Curran. And under that, we have a range of subcommittees that manage different elements of the work. So we have a research committee, we have a data quality committee, we have committees that look at outlier implants and outlier hospitals and surgeons. And we have a management team that I'm a member of, and is led by Elaine Young, the Director of Operations. And we are responsible for supporting all of those committees and for managing the contracts that we hold. And then there's the two contracts are with NEC Software Solutions. They provide the technology platform that we use to collect the data and to report the data back to hospitals, surgeons, and to industry. And then we have a contract with the University of Bristol and University of Oxford, who do our statistical analysis. So they write our annual report. They carry out the research program that I was talking about. And they also provide the analysis to support our outlier work streams. So here's the history. So 2003 was where it all started, and those first 5 years were all about accumulating data, getting good quality data, complete data, so that we can start looking at outcomes. So 2008 is when we started outlier monitoring. And that's a program that involves looking at outlier implants, but also outlier hospitals and outlier surgeons. In parallel with that, we launched clinician feedback. So that's about providing data back to clinicians to support their assessment of their practice. And that's their practice across both the NHS and the independent sector. So initially that was activity data. In 2010, we introduced outcomes data into that, and we continue to do that today. So as a surgeon, you can log on to clinician feedback and look at your revision rates, look at your mortality rates, and really drill down into what is what's driving your outcomes. 2009, the National PROMS program started. And that collects data on hip and knee from hip and knee replacement patients. And we've been linking NJR data to the National PROMS data since then, and are increasingly looking to use PROMS more in our publications and outputs. So 2010 is when ankles came on board, 2012 shoulders and elbows. We got Northern Ireland on board in 2013. And over that period, we started producing more of these feedback services. So management feedback was a service similar to clinician feedback, but it's aimed at the managers of hospitals. So it's looking at the performance of the unit rather than of the individual clinician. In 2012, we introduced supplier feedback, which is about giving industry data to support assurance of their devices. It's increasingly more important in the light of medical device regulations, and all of the major manufacturers of orthopedic devices now subscribe to our services. In 2014, we changed the way that we were funded. So initially, we'd been funded by a uplift being made to the sale of orthopedic devices. We changed to a subscription model in 2014. So hospitals and industry both subscribe to reporting services, and that's how the NJR is funded and has been since then. We also, from 2014, started to recommend that NJR data was used in surgeon appraisal, and that's a message that has been coming out of NHS England as well. In 2016, there was a best practice tariff introduced, so there started to be this incentive for people to really engage with the NJR or face financial consequences. And it's around that time that we started really drilling into the data quality of the NJR. So not just comparing NJR data with other sources, but actually identifying which cases were missing and going back to the hospitals and asking for them. And we're now at a point where 97% of cases are put onto the NJR, and in many hospitals, 100% of cases are captured. And in 2020, we launched NGR Connect, which is our dynamic reporting platform. I'm going to show you a bit about that in a bit, so I'll not labour that now. So these are some of the examples of how NGR data is being made available for a range of audiences. So we produce an annual report each year. That's a massive phone book if it's on paper. It's now increasingly just the PDF. But that's a very detailed examination of the performance of joint replacement devices across the registry. I spoke about clinician feedback, management feedback, supplier feedback. These are now all in NGR Connect, and this is a combination of static reports, so PDFs that you can pull down, but also these dynamic reports where you can identify specific metrics that you want to examine and toggle things on and off and really get a more bespoke picture of practice. We produce a personalised annual clinical report for every hospital in the country once a year, and a consultant level report for every consultant surgeon. So really we are trying to make sure that the data is in front of people as much as possible so that they can get familiar with their activity and outcomes. And then we put some data in the public domain, so you can look right now at our surgeon and hospital profile website, and you can look at every hospital in the country and see what sort of activity and outcomes they're getting. You can look at every surgeon in the country and look at their activity. So it's there's a whole range of stuff that NGR is making available and continues to make available. I've spoken a bit about outline management, so we're looking to make sure that we're able to identify where there are concerns. This doesn't mean that there's necessarily a problem, but we want to make sure that we're drawing these things to the attention of surgeons, units and manufacturers so that they can dig into the data and they can identify whether there is a problem. And we've got a documented process under our accountability and transparency model that uses robust data analysis to identify these signals, to notify, to review the response to that, and if necessary, to escalate that. We work very closely with CQC on the hospital side and with MHRA on the devices side. So these are just a few things that we've introduced over the last couple of years. So there was a report that was looking at never events in orthopedic surgery, so wrong-sided surgery, and we're able to detect that because we've got the business rules in our database that says this is a left-sided hip that's been put in the right side of a patient. But we can detect that at the point of data entry, which is often a week or two after the operation. So what we wanted to do is take those logical rules and try and create a tool that can be used intraoperatively, so that you're in theatres, you can scan all of the devices you intend to put into a patient, and it will give you a green, these are compatible, or a red, these are not compatible. So that's something that we've introduced. It's available for free for all hospitals in the UK, and it's available as a smartphone application, as a desktop application, and we've also built something that can be used to interface with hospitals' own theatre management systems. So if there's a scan for safety system in that hospital, we can include this as a module in it. So NGR Connect is something that we're very proud of. So this is really about packaging all of our reporting systems in one place. So you log in once and you can see all of your data. this is the sort of style of it. So you can click to filter. So if you're only interested in hips, you can turn off everything else. If you're only interested in primary surgery, you can turn off all of the revisions. If you want to look at your NHS practice as opposed to your private sector practice, you can look at that. And then all of that data can be printed. It can be downloaded as a table. It can be downloaded as a PDF to put into presentations. So and all of the activity data is updated on a continuous basis every day. The outcomes data, which is analysed by our team at University of Bristol, that's updated twice a year. And this is another example of the sorts of things we've got available. So this is from management feedback, and you've got these thermometer plots showing where the various outcomes metrics are on a scale of within the expected range or worse than the expected range. So one thing that we've done over the last few years is we've worked with a team at the University of Sheffield who've built a patient decision support tool. So this is using NJR data and the power of NJR data to look at how outcome is associated with the characteristics of an individual patient. So really sort of trying to give an individualized risk profile of a patient. So you can look at your risk of needing revision surgery within a certain time frame based on things like your age, gender, BMI, your PROM scores before surgery. You can also look at mortality rates. Similarly, mortality is a very rare event in joint replacement surgery, but you can look at the differences in that. And then you can change things. So if you're thinking about having a hip replacement, you can look at your risk, and then you can go back in and say, well, what if I waited 10 years? How would that change my risk? And these are things that the patients are telling us that they want to be able to have available and want to be able to discuss with the clinical teams who are supporting them. That's all online at if you Google joint calc, that will come up and you can have a play yourselves. I'm not going to do a live demo because I don't want to take that risk. So that's what we're doing now. So the future, I think, for NJR is an exciting place. We're about to go into our 20th anniversary year of data collection. So one of the things we want to do is move our price benchmarking reports into NJR Connect. So these are reports to hospitals that tell them the prices that they're paying for orthopedic devices and how that compares to what other hospitals in the country are paying for them. So it's about making sure that we can drive value in joint replacement. We are about to start looking at outliers in terms of shoulder surgery. So far it's been hips and knees, but we're keen to look at the outcomes of shoulder surgery and identify outlier devices and units. We've started to write to surgeons when they use an implant that we have concerns about, so that they consider its use. We're going to make that a system notification so that it automatically happens that if you use an outlier device, you get an email saying, please consider whether this is the right device to use. We're going to give surgeons access to lots of data on the devices that they use so that they can make informed evidence-based choices. And then increasingly, we're working with other registries around the world to see if there are opportunities to pool data, so to get more data from the different joint replacement registries and see if we can improve our ability to detect early signals. And then finally, medical devices is obviously a hot topic. The Cumberledge report has put it centre stage, and we're keen to work with NHS England to make sure that we can help support the national medical devices agenda and how that looks for specialities outside of orthopedics, how that looks for other areas of orthopedics itself, and just make sure that we're fully aligned with what's going on there. So that was it, 20 years with the NJR. I'm very happy to take any questions. Thank you.
Thanks, Chris. We won't wait till the end to ask questions, but we'll invite up our next speaker. Please do add questions to the Teams chat. That would be great. I'm just set up your presentation. So thank you. Kasim Javid is our next speaker. He's Associate Professor at Newfield Department of Orthopaedics, Rheumatology and Musculoskeletal Sciences at the University of Oxford. Kasim studied medicine at Charing Cross and Westminster Medical School, then working in London, Southampton and the MRC Environmental Epidemiology Unit. His research areas are in epidemiology and adult metabolic bone disease, focusing on vitamin D, osteoporosis, secondary fracture prevention and rare bone diseases.
Thank you, Tricia, for a very kind introduction. Michael's already concerned I'm going to speak for too long, so I'll be quick. So here are my disclosures. I put in a couple of slides just to orientate you, but what I was going to go through was my role as clinical lead for the Fracture Liaison Service database, which is a mandatory audit that's run through HQIP for all services in the UK, in England and Wales. So this is how the audit program is set out. We have the National Hip Fracture Database and the National Inpatient Falls Audit looking at optimizing inpatient care. And the FLS database really aims to make sure patients don't go back into hospital with another fracture. Based on what we talked about this morning, I just want to orientate you on the benefit of doing this. So this is some data we presented to the Japanese government that led to national reimbursement of FLSs. And here you can see the cause for long-term care or institutionalization in Japan. So dementia is the most commonest reason, then it's stroke, and then it's fractures. And on the y-axis, we've got the reduction in hospital admission from secondary prevention. And you can see for dementia, there's little evidence. Stroke is brilliant. Blood pressures after stroke, fantastic effect on reducing readmissions. But osteoporosis, drugs, and fractures, close second. So it just shows the impact. And this is some data that OHID actually shared, which looks at the top 20 conditions driving emergency bed day occupancy. And you can see, obviously, pneumonia was number 1, but fractures of the femur were number 2, and also fractures at other sites. And we know that 50% of femoral fractures have already told us they're coming because they've already had a fracture. So osteoporosis is really important and very reversible. So what do we do to address that? Well, for inpatient care, we have the National Hip Fracture Database set up since 2017. Actually, Chris was instrumental with that, so he then left for the NJR. And if you go to the website, there's lots of information. The 3 audits now are framed around key performance indicators, and you can see the indicators listed here for the National Hip Fracture Database, and these are then displayed by centre. We also have longitudinal data using run charts at the centre or country level, and here you can see the impact on mortality over time going down, which is a great success for the audit, and then time to admission actually going up, reflecting the current burden on the NHS. The NHFD, just like the NJR, gives a lot back to the community. So for clinical services, they have an improvement repository, and there's quite a strong patient focus. We have an independent patient and carer panel, and they've developed lots of resources to help family members of people who've had a hip fracture, and there's even a QR code to access the guide. Then we have the National Audit of Inpatient Falls. These are people who have a hip fracture while they're already in hospital. There are about 1,300 of those in the last report, and they have set standards for what happened before the fall that led to the fracture. Did they get a good assessment of their vision, continence, postural hypertension, and critically, what happened after the fall? And they've identified that actually what happens after you fall over and break a hip in a hospital is too variable to be really due to patient factors, and they're trying to standardize that post-fall care. So there's a systematic checklist that every patient gets access to. And just like the NHFD, they've created a repository for patient and for clinical resources, and these documents are phenomenally successful. So the measurement of lying standing blood pressure, about 150,000 downloads. So these are very accessible. Nurses, other healthcare professionals are accessing them, and they're very useful clinical resources that have been used and refined and actually help improve service delivery. And the clinical audit that I help run is called the FSDB. This has been running since January 2016. We've got over 400,000 records now, and you can see the number of participating FLSs went up and down during COVID, and we're around 77 now. These are the key performance indicators in detail that we record for every patient who's submitted, that go from identification, assessment, treatment recommendation, and then what happens after they leave hospital. So ours is a more complicated pathway because we follow the patient rather than the healthcare service. So we follow the patient from admission all the way through to monitoring in the community, and that has its own unique challenges. So what has impact been? Well, one of my favorite impacts is maps. So we love maps, and you can look at, we produce maps every year. Each circle is a trauma unit that should be covered by an FLS, and we really want FLSs to participate in the audit because then we can measure their quality. Red means, grey means we have no idea what they're doing because they're not participating, so we can't judge the quality. There may be an FLS, can't measure the quality, but if you look at the quality of the ones that are participating, there's a lot of variability. So red means they're finding less than half their patients being submitted into the audit, amber up to 80%, and green over 80%. And nationally we can use this because you can look at areas that have got no FLS, you want to target your investment. We talked about reducing inequality. Here, to reduce inequality, you've got to get the FLSs started and get them participating. And in these areas, it's more about quality improvement. Get the existing services what they're set up using the model of healthcare improvement to become more effective. So why do we produce all these tools? So we have a dashboard, and every hospital's on this, and you can look at national averages, regional averages, you can compare with other institutions, and where there's variability, the FLSs can learn from each other. So if you're red, go somewhere that's green. If you're green, go and teach someone who's red. Where everyone's red, we probably need national tools and national levers. So for monitoring, we're setting up a GP-based EMIS search that's being piloted in HSNs, and then hopefully is going to be adopted, that's the vision, across all HSNs, and that will allow the GPs to actually very easily monitor patients on therapy. So the run charts are really useful. They show national trends, and here you can see the reduction of mainly driven by non-hip fractures during the COVID pandemic. But they're essential for healthcare improvement. Without live data, you can't improve. So every hospital has this. You can look it up. It's freely available on this website. You can look up your hospital, and if they're participating, you can check each of the KPIs, and you can see how the different PDSA cycles are put in. PDSA cycle 3 is important because we thought that we'd finished and we'd done really well, but then some new nurses started and we forgot to update the induction system. And unless we were capturing this data routinely, we never would have known that the new nurses weren't doing the correct falls assessment. So it just shows the power of having just plow through the data and routinely check your key performance indicators. Again, we provide a ton of resources. You can look at them on the website. We have resources for everything from sample Excel spreadsheets, documents, and loads of guides. And we also provide support where people can email or phone to get support in participating in the audit. We work very closely with the Royal Australia Society, and that's really important. We want to work with our third sector champions to help us deliver our vision. No one's really mentioned this, but we've got something called the National Data Opt-out. If you don't know about it, it will be coming to you soon. It is a thorn. It does make things complicated, but we've addressed this, and we've now created a work-through pack. So if you are part of the National Data Opt-out audits, then it's an easy step-by-step way to actually make sure you submit data that's been filtered for that. But we recognise just giving data isn't enough. We've been doing the audit for ages. The variability is still large. So what we've done is we've run improvement collaboratives. We've done one for FLSDB, and then we did one for NHFD and NAIF. And this is where we take a group of services and we run them through 3 learning sessions, with coaching calls in between, and we measure the outcomes in terms of confidence, but also KPIs. We haven't looked at the KPIs yet, but you can see here over a range of indicators, from setting up a QI team, involving patients, stakeholder engagement and scaling up, their reported confidence before they started the program and afterwards. Everything went up, but interestingly and probably expectantly, including patients in the QI team is still a problem. Many NHS services don't have patients as part of their QI team, and getting good production is a problem, and then stakeholder engagement was the other issue that's come up. Because we've done this, we've now improved it, so for our next collaborative, we'll have more focus on those indicators. Patient benefit, so reductions in fertility and mortality, widely publicised by the NHFD, and for the FSDB, each bar we go from 2018, 19 and 20, and the height of the bar are the number of units who have met that key performance indicator for amber, which is 50 to 80%, or green, more than 80%. So you can see over the years, everything's getting taller for each of the KPIs, and HQIP like this because more patients are getting good services. Research impact, so we have a scientific and publications committee, and that's very active. Over 45 publications, 99.9% from the NHFD. They're very active. There are 20 open applications, including the Versus Arthritis Reduce study, which has been really important in pushing inequalities in hip fracture care. You can go through this route and do visit the website because there's a lot of data that's already publicly available. So you don't need any permissions. There is so much of our data, because of our rules, we have to put in the public domain. Actually, a lot of it is out there for you to use. You can go to the FAP website, you can download the site level data, and on the data.gov website are all of our facilities audits and all that other data. So before you think it's quite hard to access the data, your question might be answerable by data that's already freely available. It's just linking the data set that's the key. So the question was lessons learned. What makes a successful audit is reducing the barriers and improving the value. And I hope I've shown you the value participation for quality improvement, but you can't just focus on that. You have to reduce the barriers. So you'll come up with a data set, reduce it by 90%. Okay, nearly all registries ask for too much data that isn't really analysed. It's just the fact of nature. If I went through all the audits, looked at all the data points and said, how many times has that data point actually been used to improve patient care? Very few will be. So most data sets are too big. Ours is too big, and we're trying to reduce it because the primary aim of the registries is not research, it's just service improvement. It's not even impact. So if you take that view, actually your data set is very small. And we're trying to, in the FSDB, make sure that every question links to a key performance indicator, and that really shrinks your data set. Be really clear on your legal basis for sharing patient data for reporting and also for research. And the national data opt-out is going to come, and the direction of travel is every audit will have to do it because it's just part of patient access to data. And you know, there are some exempt audits. I'm not sure that's going to be the case in a few years. It may go the other way, but I'm not sure. And then when you're linking to NHS Digital, it just takes ages. So there's a 2-year delay for mortality reporting. So if you're contingent on linking to another data set for your impact or improvement work, be careful. The big one is reducing data entry. What should happen, because all NHS organisations commission their own healthcare record system, the healthcare record system should export to the national audit automatically. That should just be part of the contract with every EPR provider. It doesn't happen, and if you do want to do it, the setup is horrendous because trying to amend an EPR is very difficult, and if you want to change it, it's almost impossible. It takes too long and it's too expensive. So what happens at the moment is that you have your hospital record for your clinical data, and then someone has to re-import all that data into a separate database, which is fine if you've got 100 patients, but if you've got 1,000 or 3,000 patients, that's fewer patients your service is seeing, and there's a huge inefficiency. Another model, if the EPR system doesn't work, is to have a separate database where you do your clinical service that then exports to the hospital record system and exports to the national database, or wherever you are. That's a bit more tricky. Some services are doing it very well, but then you have issues of how you integrate with an EPR system. So I've finished now. So I asked the clinical leads from NHFD, NAIF and Fracture Liaison Services, what are the strengths, limitations and what are our draws. So our main strength is actually the patient care panel. We have weaponized our data and actually produced resources to help patients help support healthcare delivery. And we've tried to use the data to actually project manage sites to quality improve. The sites are just too busy, they've got so many clinical commitments, they actually need a coach to help them get through the data. I've listed all the NHFD run charts and they're all listed. I think they've done an amazing job of actually leading the world in hip fracture databases. The NAIF, through their clinical resources, have had a phenomenal impact in standardizing care. And what we've done in FLSDB is try to get the dashboard up. And really, we want a service to think, if you are a hip fracture service, or you are a full service, or you are an FLS service, you're not a service unless you're part of an HCRIP audit. Unless we're measuring what you're doing, actually, we know when we measure it's not great, you're going to be in trouble unless you do. Limitations I put there, I've mentioned the NHS Digital. The main limitation with NAIF is limited to inpatient hip fractures, which at the site level is just too small to run quality improvement. There just aren't enough events, and they're going to expand that to all inpatient falls that lead to major injury, potentially coming forward. And then for us in FLSs, when COVID hit, it was the first thing that got redeployed. So a lot of our services shut down, and now we have the traction of trying to get services set up for every trust. I put the NDO as a draw. It's probably a limitation, but we've done all of our resources. We've set up cafes and spreadsheets and videos. I think it's a draw. We've minimized it as much as possible. So I'm just a small cog. I'm the clinical lead for FLSDB, and I also help with the QI program, but you can see everyone else in the program who actually do all the hard work and deliver it. And the project managers are essential for this because they actually drive the projects going forward. So I'll finish there with the strengths, limitations and draws for audits. Thank you very much.
Thanks very much, Cassim. If you want to add questions, please do to the chat or we wait to the end. Our next speaker is James Galloway. James trained in medicine in Bristol, graduating in 2001. He undertook postgraduate training in Manchester, completing his PhD in clinical epidemiology with the Arthritis Research UK versus Arthritis Epidemiology Unit. He moved to King's in 2012. His research group works on areas including pharmacovigilance, health outcomes and quality improvement in the field of rheumatology. Dr. Galloway is also a consultant rheumatologist at King's College Hospital and has specialist interests in the areas of inflammatory arthritis and biologic therapy, and also in sarcoidosis, if I said that right. In addition to research and clinical roles, Dr. Galloway is a faculty member of MBBS undergraduate course in medicine, has several streams of research aligned to medical education. So handing over.
Thank you. I need to get a shorter bio, don't I? So thank you very much. And it's a pleasure to speak here. And it's very nice being in good company talking about audit and QI. I should declare, I come from a background, my research interest started out doing pharmacovigilance. And I spent quite a lot of time studying drug A, drug B, and which one is safer. And conclude, maybe drug A is safer than drug B. And I was a skeptic about QI. I thought it was methodology light, not particularly focused around testing hypotheses or generating hypotheses. And when I got involved in doing national audit, a lot of reading, a lot of thanks to the enormous wealth of information produced by the Health Foundation, King's Fund, and it struck me when you start looking at health quality and the differences in quality provision around the NHS, that all the previous research I've done saying drug A and drug B have a difference in safety of this magnitude, that pales in comparison to the magnitude of difference you see from hospital A delivering care versus hospital B. And that really struck me just how important it is. I think, we acknowledge healthcare is complex, and in rheumatology, in looking at musculoskeletal health, it is we've already heard this morning, it depends on many things. We've talked about deprivation, ethnicity, but comorbidity. And our goal is that we provide high quality care to all these patients to improve the health of our population. But to achieve this, we've got to measure what we do. We've got to be able to record what we're doing, and then have some mechanism of saying, well, we're doing it well or we're getting better. And this is where this concept of quality improvement, which I think I would still say of all the bits of research I've ever done, except for I did once publish a guideline which had some quite strict recommendations about monitoring for eye toxicity, which caused a lot of hate mail. But aside from that, the national audit programme, being involved in that, has resulted in a lot of clinical colleagues saying, why have you done this? This is the worst thing that could have happened to me. Because it's a huge amount of effort to collect the data, to put the information in such that we can measure quality. They say, you know, does it really make a difference? And I'll come back to that, because I have under no illusion it does, and we've seen so many other audits already described today showing it, if you measure things and show people and visualize it, it does. They then say, why do we need to keep doing it? Can't we just do it once and then we're done? And, you know, that was put to bed years ago in other industries. You know, if you manufacture new cars, you don't just check every third car coming off the manufacturing line works well. You always check all of them work well. And the other bit is what constitutes good. And this is about saying, well, you need a benchmark that isn't how are you doing compared to yourself, or how are you doing compared to yourself last month. It's how you're doing compared to everyone else, and having national benchmarks. So for that, I think in the UK, we're enormously fortunate with HQIP, with having this national drive to say, well, let's look at performance across the NHS services in England and Wales. I wish it was more routinely Scotland and Northern Ireland. It's, you know, the NJR, I think, has been fantastic in moving across 4 nations. For rheumatology, we started going back to, it's about 2014, the very first iteration of the national audit, but 2018 in its current format, where we started to collect information on early inflammatory arthritis. So people presenting to NHS secondary care systems in outpatients. And that's quite important because it's a relatively unusual audit that we're collecting longitudinal information on people in an outpatient setting for whom there isn't a HES diagnostic code for them. So it's a data set that doesn't exist somewhere else to draw upon. We collected information on people referred with suspected arthritis. So whether they have arthritis or not, we still collect information on the time it takes for them to be seen by a rheumatologist. If they have arthritis, we then collect additional information over the first 12 months of their diagnosis. So we collect information on their disease severity at their presentation, and then again at 3 months and 6 months, whether they respond to treatment, what treatment they receive. And we also have linkage to some of the other NHS resources, so we could look at things like progression to need a joint replacement in the future. It is quite a lot of data entry, though, and in the first year, we collected 21,000 patients' data who had had suspected arthritis, of whom actually only 35% ultimately had an inflammatory arthritis. Most people took part. About 209 out of the then 211 CCGs returned information. Every health board in Wales returned information. But that belies the fact there were large pockets of the country in whom some trusts just did not engage with us, or even within a trust's specific hospitals didn't engage. And a common citation for not engaging was, it's too much. I've got to see 30 patients in my list in clinic, and I don't have time to additionally add the data for you. The results are striking. We saw that there was substantial variation, not just in process measures. And one of the things that we were learning, and I think in rheumatology, we didn't know for definite that measuring time to treatment would correlate to whether you get remission as well. So whether the disease outcomes, and in rheumatoid arthritis, we talk about remission as being treatment response. And this graph shows, well, the first thing is we showed that being treated more quickly corresponded well to getting a better clinical outcome. So it mapped to what the clinical trials had showed, but it also showed there were substantial variations in the country. That wasn't a surprise, but it was perhaps interesting to see where that variation was and then to target intervention. But the other bit that struck me from the outset was that the hospitals that returned fewer patients to the audit also were the ones that probably had, that tend to have less well-performing care. And this wasn't a surprise, because the hospitals, I went out to visit a lot of hospitals, and you'd go out and visit hospitals, and the ones that were struggling, you'd see the resource, and they were often working in resource-poor settings where they were really struggling with the time and effort to get the data entered to the audit. And you could appreciate that their priorities were delivering a bare minimum service and not about delivering the audit. Whereas the well-staffed centres with good infrastructure had plenty of time to not only see the patients, but also put the audit data in. And so that's a challenge, because data quality predicted outcome. So this is another way that we could potentially change the way we do this. So you'll notice in my title of the talk, I talked about other ways of routinely collected data influencing this. And so we've been really interested in the pandemic about bringing together data sets, this concept of federated data sets, whereby you can join up information, which we have enormous amounts of information around the country, held in secure data sets, but they're disparate from each other. They're not talking to each other. Ben Goldacre's group in Oxford set up this setup called Open Safely, pulling together primary care and secondary care, and really interestingly in rheumatology, biologic prescribing data for the first time. So a data set that we previously thought was impossible to access was joined up so that we could start to see joined up diagnostic information, treatment information, outcome information all in one place. It's a really interesting platform because using this platform, you never see anyone's data. The patients don't need to consent because no individual patient data is shared. So just to give you an idea of how this works, the data sit in a secure database. A researcher applies to the database with a relevant question. At the moment, those questions have to be related to the questions of COVID or healthcare in the context of COVID. So say I've got a question. I say, I want to know how many people have been diagnosed with rheumatoid pre and during the pandemic. They approve me the permission to answer that question. I then write the analysis code and I give that to the database. The database then allows that code to run. So before I do this, they give me a dummy data set to test the code to make sure it works. But then I get back an output table. So I never see any patient level information. No patient data is ever shared. So it keeps the information secure. There's another catch as well. In order for me to get permission to do this, I also have to then publish all the code I wrote to get that patient data, which means anyone else who wanted to ask the question again, they're not starting from scratch. They're starting from an already existing code. And I think historically in research, we've seen our code writing as being, the analytics code is part of our intellectual property about doing the work, whereas this is turning it on its head and saying, no, this is public. So Mark Russell, who is sat in the room, for those of you in the room, Mark has done this work in which he has done exactly that question with Open Safely. What is the instance of the various different types of inflammatory arthritis pre and then during and then in the recovery period from the pandemic, showing how diagnoses absolutely fell off a cliff edge at the start of the pandemic and then picked up, although have not rebounded perhaps as much as you might expect, assuming the actual instance of rheumatoid itself didn't change during the pandemic, although of course it may have done. Broken down not just for all diseases, but separately for rheumatoid, PSA, axial spondyloarthritis. And actually then it took it a step further to say, well, what about how long it took them to get their first drug? So we looked both at first drug, but also first rheumatology appointment. But I've shown here time to first drug. And you see striking variation around the country. I'd suggest you just glance your eyes down and look at the southwest, maybe compare that to London, as in London is doing far less well than the southwest in how many people have a first CSD-MARD prescription within 3 months. There's a caveat to this though. Well, there's a number of caveats. The first is the diagnosis is dependent on a GP-coded dataset, and that's imperfect. And secondly, the treatment here is a measure of treatment delivered in primary care. So if the hospital prescribes the first drug, we haven't got that. So this is an imperfect measure, but it is still a fantastic, because this could be presented in a real-time live dashboard. And the data already, no clinician needs to put any piece of information into a data set to be able to do this. This is obviously at regional level, not at hospital level. This data set only has permission to be used for COVID-related research currently, and we're fighting hard, and anyone who wants to help try and fight that battle to change that, please speak to me afterwards. But our plan is going forward is that we can actually perhaps do a hybrid, because I don't think that's perfect for doing the national audit, but I think there is probably a middle way. Because HQIP said to us, and I said to the BSR, The National Early Inflammatory Arthritis Audit is good, but to make it stronger going forward, there's an issue that you need to expand the diagnoses you're collecting, because we've got a concern in rheumatology. We have a lot of rare diseases. Rare diseases historically get underrepresented in quality measures because rare diseases are hard to capture. And I've also been worried that if you look at what we're asking people to do in the National Arthritis Audit, it's to say, see people quickly. And if I had to choose the disease I'd like to see quickest in rheumatology, it's probably not rheumatoid, it's probably vasculitis. Someone with giant cell arthritis who could go blind within days, they need to be seen the quickest. And so there's this slightly perverse incentive in the audit that by taking part in the audit, you may actually not be designing your service in the most efficient way. So the new audit that is going to go live from next spring will be to say we're only going to collect people with a diagnosis of a confirmed rheumatic disease, but we're not limiting it to rheumatoid. It's going to be all rheumatic diseases. And we're only going to collect information on how long it took them to get the diagnosis and what the diagnosis was. And then everyone at the patient level will go into our PROM program. So we'll collect outcome data using patient-reported outcomes, except for rheumatoid arthritis, in which we will collect the NICE quality standards at 0 and 3 months in terms of a DAS score. But for everyone else, we will collect outcome measures based upon what we can extract through Open Safely. And that is the plan we're pushing for, such that we could look at, say, for example, vasculitis, the instance of renal failure or stroke, or for lupus patients, heart attack or stroke or need for dialysis, and so that the outcome measures are captured in a way that requires the clinicians to add no information. I think in future, how we do this and how long we follow up, there's all sorts to be defined, but the potential to do this across other audits is enormous. I will stop there. Thank you for listening. I hope I didn't overrun.
Thank you. Our next speaker is online, Romana Burgess. Are you setting up? Yeah. So Romana Burgess is a clinical academic physiotherapist who works clinically as a consultant physiotherapist at MSK Lead at Sandwell and West Birmingham Hospitals NHS Trust, and academically as a research fellow within Kiel, University of Medicine and Primary Centre for Arthritis. So Romana completed her PhD in benchmarking community and primary care MSK services and is passionate about improving and standardising data collection in this area to provide a better understanding of variation and inequity of care provision and empower targeted quality improvements. Romana is also an MSK champion for versatile arthritis and been part of the inaugural MSK Champions programme. So we'll hand over.
Thank you, and thanks for that kind introduction. So my presentation today is slightly different to those that have preceded. So instead of talking about these fantastic existing national registries and audits that we see, I'm going to talk to you about how we would like to develop a further national audit, and for particularly the area of community and primary care, which at the present time doesn't have a national audit to service those MSK patients. So I'm going to tell you a little bit about our study team, what we're aiming to do, the different phases of our study that we're developing, and also for any community and primary care services out there working within MSK, how you can get involved. Next slide, please. So this is our immediate team. So I'm working within Kiel's School for Primary Care Against versus Arthritis, and working with Professor Jonathan Hill, Professor Kelvin Jordan, who I think probably many of you are aware of because they've presented previously within these meetings. And also we're supported by our clinical trials unit, by our study coordinator. We're also supported by our patient experience group who've supported us very much within our protocol and how we've developed our study goals and objectives and how we shape that going forwards. And again, we're also working very much with our community. So we've already launched a community of practice. So this is very much trying to develop with community services and primary care MSK services to try and do something collectively that is useful to that community of practice. Next slide, please. Perfect. So what are we aiming to do? We're aiming to pilot methods to set up a national audit programme to continuously collect and report quality data specifically for MSK community. And by that, I mean MSK community, largely physiotherapy-led services, and for primary care MSK services. And again, by that, at the moment for the audit, we've narrowed that to mean first contact practitioner services, so FCP services sitting in primary care. And what we're aiming to do is understand then the quality and equity of care for patients with musculoskeletal conditions presenting in primary and community care. And we know, as has been discussed largely today, what inequities exist across MSK care, and we really want to try and understand that better in order to find some of those answers to improve. So in terms of our study, we're looking to recruit a minimum of 20 MSK services and 20 FCP services. And I'm delighted to say we've already put out our registration of interest. So for any services that are interested in being part of this piece of work, and we've already had 30 MSK services that have put themselves forwards to be considered to be included, and 25 FCP services. So I think that shows, again, the amount of interest there is in standardising the way that we collect quality data, and also being more supported in then what quality data means and how we interpret that and how we use it usefully to actually try and drive quality improvement for these patients. So there's three parts of the study. So phase 1 is our setup stage, which is where we are currently, and we're very lucky to get funding from Pfizer for this part of the study, and this started in April this year. As part of that, we've got our Keele MSK dataset. Again, we've worked hard to get consensus on these metrics, and as was discussed earlier, we've tried to minimise that as much as possible, and I'm sure that will get iteratively improved in the years as we go forwards. We've also aligned the great work led by Chris Mercer as part of the primary care group in the NHS England programme, so aligned it very much with the high-level metrics that came out of that working group. We've also developed our front-end data collection platform methods, and we will continue to develop this going forward. So we're really excited that we got some funding from the British Society of Rheumatology, and we're looking very much to learn from work that James has just presented for the National Early Inflammatory Arthritis Audit, and to start to utilise that front-end data collection platform and expand it to this wider group of patients. We're also going to allow services, so particularly MSK services, to collect data using existing platforms, because again, there are services that are already doing this and they're doing this well. So again, as long as they meet our data standard, they'll be able to carry on using existing mechanisms to collect their data and then export that data to us at Keele. And that will all come into our Keele backend data repository. Next slide, please. Great. So we launched our community of practice in October, which is also when we launched our registration of interest. And again, as I say, we very much want to take the MSK community, so patients, stakeholders, policymakers, other people already successfully driving audits in practice to be part of that community and help us take this forwards and make it a successful programme. As I say, expressions of interest are open, so if there's anyone listening to this talk now who is sitting in a primary or community care service that wants to be involved, please do go to our website and join up. We're at the point of going through ethical approvals, and hopefully that will be go through that within the new year. We're learning very much from other work that's already undergoing in a school, in Keele School. So we've got the MIDAS project led by Professor George Peat, again, that's been presented previously in this meeting, learning about how we better integrate data from multiple sources. And also we're very much learning from the work, again, that James has just presented. So how do we best pull this data together and make that data collection process more simple in practice? Next slide, please. Phase 2 that starts in April next year is when we start our data collection. And as I say, data collection will have various pieces to this. So using, as I say, the British Society of Rheumatology's EPROM collection, I think this will be particularly useful for the likes of FCP services that currently aren't collecting this as standard across, as I say, because that's a fairly newly developed part of practice. We'll also be collecting data from the electronic health record as well, and this is particularly in the format for FCP services of a specific template. Again, we've got this Midlands FCP template that was actually developed as part of Keele's MIDAS project. It is made and we're ready to share it in EMIS format, and it is currently just being developed in System 1, and that should be ready again to be shared imminently. So again, if services are out there working in FCP clinics and they want to get hold of that template, whether they want to be involved in the study or not, please do contact us. Again, this data alongside organisational data. So again, it's really important, as we've heard, to understand the organisational pressures people are under. So we know there's a huge inequity again at the moment, particularly in MSK community services in waiting times, and how clinics are set up. So how long clinicians have to treat patients, how long patients have to wait to get into those services, and staffing, so workforce, skill mix. Facilities. So there's all sorts of different things, again, that impact on quality. So we will also be collecting all of that data from service leads and service managers as part of this piece of work. And all that data will then sit in our back-end data repository. Next slide, please. So in this phase 2, as I've mentioned, we're very much looking forward to working with James's team, and we'll be collecting that data as discussed with that EPROM platform and with net solving. Next slide, please. Great. And finally, we've got the analysis and reporting phase. And again, it's just so exciting to see what everyone's presented today on the dashboards, the visualizations, and how important this data is to report back in a useful way to actually drive that quality improvement. And we really we will be coming to all of those different audits, I think, that we've seen this morning, and trying to learn what we can from that and see how best to represent this data, as I say, to help patients understand it, to help clinicians understand it, to help managers to lead these services, and to help researchers use this data usefully moving forwards as well. We will then also do the national benchmarking piece. So we'll be using our tried and tested case mix adjustment model so that we can then start to compare nationally how different services are doing. As part of this study initially, we're going to do this in an unidentified way. So you'll know where you sit against your peers, but you won't know who those peers are. And as we get our methodology kind of developed and as we get this set up, we think that's the most appropriate way to do this in its initial stages. We'll also then start to look at auditing against defined quality standards. And again, we've got the newly developed CSP, Musculoskeletal Physio Service Standards, which will form part of this piece of work. Next slide, please. And thirdly, the last piece of work, which we haven't got funded yet, but we're looking for funding for, and we've already applied for some funding towards this, is our qualitative work, which again is another really important piece to help us understand then where we're at once we start to see data coming through and once we start to develop those dashboards and visualizations. So again, this will be in the form of developing focus groups with patients, clinicians, managers, commissioners, every type of stakeholder that's involved, so that we can better understand, again, as has been discussed earlier today, the barriers, the enablers, the learning, and how we can iteratively improve this, make it as little burdensome as possible with maximal impact, and actually, as I say, see that data usefully used to drive forwards quality in practice. And we're looking to collaborate with other higher education institutions. So we want to collaborate with Professor Lisa Roberts at Southampton to lead on this qualitative piece of work, and also with UCL and particularly Emma Dunphy to help us with the behavioural change side of it. So again, we want to look to develop clinician level dashboards so that you can see how your behaviours sit across next to your colleagues, both at a local and national level, and start to use that hopefully to drive behaviours in practice. So again, lots of exciting work, hopefully, that we can do as an offshoot of this data collection process as well. Next slide, please. So finally, this is just a link. I'm assuming these slides will be shared. This is a link to our webpage. So if anybody wants more information on the study, whether you're a researcher that wants to support us with any of these particular aspects, or a clinician, as I say, working in these practices that wants to sign up or hear more about it, please do go to our website. And as I say, also do feel free to contact me for any further information. Thank you.
Thank you, Roanna. Okay, so our final speaker. So our final speaker is Ima Silva. Ima is a fourth-year medical student at the University of Oxford. She did a third-year research project with Dr. Anushka Soni at FMRIB Pain, group where she did a cross-sectional study using data from UK Biobank to look at the neural differences in individuals with chronic widespread pain or fibromyalgia and the effect on sleep. They presented their abstract at the British Society of Rheumatology in July. So, Dr. Clark?
So the title of our project was investigating the neural differences in individuals with chronic widespread pain, fibromyalgia, and the effect of sleep. A cross-sectional study using data from UK Biobank. So I'll start off by defining some of the key terms. Fibromyalgia is a musculoskeletal pain condition that affects roughly 2% of the UK population. It is characterised by chronic widespread pain. This is pain that is present on both sides of the body, above and below the waist and axially, and has been present for at least 3 months. Fibromyalgia is a polysymptomatic condition. In addition to the pain symptoms, patients often present with sleep problems, fatigue, and cognitive effects. These include problems with low mood, memory loss, and concentration. There has been some evidence to suggest that there are structural changes in the brains of those with fibromyalgia. However, the exact neural mechanisms for this are not fully understood, and the studies to date have been quite small-scale studies. So the aims of our study were to use the existing literature to identify regions of interest thought to be involved in the pain mechanisms in patients with fibromyalgia, and to use data from UK Biobank to compare these brain regions in the controls and cases. And finally, investigate how pain and low sleep duration can interact with each other to affect these brain region volumes. So as I mentioned, we use data from the UK Biobank. This is a large-scale biomedical database with data on 500,000 participants. So this includes physical measurements and also factors on their mental health, and also things like genetics and serology data. They have an aim to image 100,000 of their participants, and so far they've already imaged about 60,000 of these participants. They also have a questionnaire, and the recruits will go through on a touchscreen and answer questions relating to their lifestyle, diet, exercise, and also pain data. So this flowchart summarises how we selected our participants. So out of the 500,000 recruits in Biobank, we looked at those who had brain imaging data, and of those we looked at the recruits that we defined as cases, i.e. they had a diagnosis of fibromyalgia as confirmed by their medical professional, or they met the criteria for chronic widespread pain. And from these 619 recruits, we looked at the 429 who had these symptoms at the time of imaging, and also looked at 429 age and sex-matched controls. These were healthy recruits within Biobank who had no pain at the time of imaging, and they also didn't have any history of other common pain conditions like osteoarthritis and rheumatoid arthritis. So this diagram summarises the brain regions that we looked at. So this was based on the existing literature and included the prefrontal cortex, the insular cortex, which is located within the lateral sulcus, the parahippocampal gyrus, the cingulate gyrus, the precuneus cortex, the thalamus, and the pallidum. And those two, the pallidum and thalamus, are subcortical structures. This table summarises the characteristics of our participants. So they were age and sex matched. So all of the participants had a mean age of 62 years. 77.4% of them identified as female. In the controls, 88.3% identified as white. 17.5% had a low sleep duration. This was defined as less than 7 hours of sleep in a 24-hour period. And 19.1% of the controls had at least one mental health problem, as diagnosed by a professional. In contrast, 92.1% of the cases identified as white, 39.6% of them had a low sleep duration, and 44.3% of them had at least one mental health problem. So the first thing I did was look at the global brain volume differences between the cases and controls and confirm that there were no significant differences that would have to be adjusted for when conducting statistical analysis. I then did independent t-tests
at looking at the regions of interest and found that all of these regions listed here had a significantly smaller brain volume compared to the healthy controls. And they're all involved in either the emotional aspects of pain or in pain regulation modulation. I then did 2A ANOVAs to look at the interaction of pain with a low sleep duration to see how the two can act together to impact the brain region volumes. And in all of these regions, there was a significant interaction of those two factors on the brain regions. Finally, I adjusted for confounding variables that could potentially have impacted the results. So I used a hierarchical linear regression to adjust for mental health, age, and sex as confounding factors. And the significantly smaller brain volumes still persisted in the left insular cortex and the left anterior parahippocampal gyrus. And the significant interaction between pain and a low sleep duration also persisted in these 5 regions shown. Finally, the strengths of the study were that it was a large-scale study, so there was significant power when conducting statistical analysis. And I also addressed confounders that may have influenced the results that we found. However, there were some limitations. There is an innate reporter bias in Biobank in the fact that those who attended all the imaging visits and assessment centres would have had to be well enough to attend all of those. So it may not be as reflective of all patients with fibromyalgia. Also, the variables were self-reported. So for example, their sleep was how many hours they'd reported to have slept rather than something that was measured and kind of controlled in that way. Finally, sleep duration included naps. So patients who may have not had a good quality night's sleep may have accounted for that by napping during the day, and that won't be reflected in the results that we saw. So overall, the conclusions were that there are brain volume differences in the cases compared to controls, and sleep can interact with pain, and this is associated with further reductions in the brain region volumes. The wider implications of this study were that it provides further evidence that there are morphological changes in the brains of patients with fibromyalgia, and this helps to kind of shift away from the idea of it as a psychosomatic disorder, as it shows that there are differences in their brains. And it leads on to a discussion of the directionality of the sleep and pain relationship in these patients.
Thank you. Thanks, Eva. That comes to the end of our presentations. So we're ready to take some questions. So we have 2 speakers still online and 3 in the room. So would anyone like to start? Everyone's getting hungry. See if there's any questions in the chat. There's some comments in the chat. Just commenting on the presentations, a lot of interest with the National Joint Registry and with Rowana's work as well. And there's a link to the Keel audit if anyone wants to sign up as well, or disseminate. Fantastic, thank you. Rowana, is the FC, this is for Rowana Burgess, is the FCP template you've developed purely for collecting outcomes, or does it incorporate clinician assessment too?
Yes, so the FCP template, it's I guess you could call it a bit of a caching up template. So in terms of what you do as a clinician will also be collected as part of that template. So whether you investigate, whether you send to social prescribing, those kind of things will all be captured as part of that template. So yes, I can share, as I say, if anyone specifically wants access to that template, I can share that.
Thank you. Any other questions? This has been recorded. It will be online. It'll be on our YouTube later as well. So yeah, you can watch it back if anyone has lots to think about. So there.
Thank you, Patricia. Thank you to the speakers. So if there's no questions, we'll move on to our last segment, which is I introduce Andy. Andy Bennett is our National Clinic Director for MSK Conditions at NHS England to give some closing remarks.
Thank you. So I'll try and be brief because I think we're all getting a bit hungry. Firstly, a massive thanks. So thanks to the invite, but also thanks to everybody who's participated, both online and in the room, with this really insightful as Benjamin, as you said, fascinating and in some lights concerning meeting. And thanks for doing it in a hybrid way. I think the first hybrid meeting I came to as we came out of the pandemic was this equivalent last year. And that went remarkably well. And I think this has gone remarkably well too. And it's great because it enables so many more people to join and engage and for us to share the messages. So thank you for setting that up. So to summate, I think, we all have a shared vision to enable best MSK health. And I think what's come loud and clear through all presentations is we have a shared ambition to enable equitable, high quality, high value care. And the use of data to drive evaluation and quality improvement is absolutely key to enabling this vision and enabling this ambition. And what's been fantastic today is to see so much work across the broad envelope of MSK. So we are a massively broad church across setting, primary, community, secondary care, across speciality, rheumatology, orthopedics, pain management, etc., but also across the life course. And I think it's fair to say that we've seen examples of work reflecting that broad scope. And of course, integrating our provision across that broad scope is absolutely key to help us achieve that vision and ambition. I think it's also been a really good opportunity to reflect on lessons learned and to share them. Really hits home listening to about our national audits, which were fantastic presentations, and thinking about the work Ro is doing with regard to the MSK audit, which if we can get in place would be, I think, a game changer for us in MSK. But what is our challenge? Well, we're in a very complex political, economic, social context. I think our discussions and our questions have reflected the sort of bilateral challenge that we need to balance of restoration in the short term and productivity and performance and reducing waiting times and all that jazz, with transformation of services in the medium to long term, reflecting the population health approach we need to take. And within that balance, I think it's thinking about, well, what are we actually trying to do? If we're going to enable quality evaluation, quality improvement, how are we actually going to do it? And that's about using data and the work we're doing to actually enable local leads who have the best understanding of their constrained resources, but also their population need, to be able to deliver quality improvement to adapt and adopt to the needs of their population. And I think that's the challenge for us moving forward, is how do we take this wonderful work, but how do we make it generalizable to a population and a system that is massively challenged, but also is massively sort of variant and heterogeneous in its nature? And I think that would be the big thing I would like to take away from today, is how we can do that. But the massive positive is that the fact there is so much work going on in MSK, that is great. The fact that it's reflecting the broad church, the fact that the key sort of cross-cutting themes related to inequalities are embedded in it, and the fact that we can get together in a hybrid way and reflect on that. So thank you all. I think it's been a really good morning, and I look forward to working with you further.
Thank you, Andy. Just to add on to the thanks. So thank you to the team here for helping to put this meeting together. Thank you for the people attending here. I appreciate some of you have travelled quite far. Thank you to the people online for staying with us for the few hours that you have. And lastly, most importantly, thank you to the speakers, because of course this meeting is not possible without you. Our next meeting will be in early June. We'll hope to get the data out to you in the next couple of months. We have a feedback survey that I put the link into the chats, and you have that in your agenda in front of you. Please take just a minute or two just to complete that so we can improve this meeting, but also to give us some ideas of what you'd like to see at future meetings as well. For the people in the room, we have a Christmas-themed lunch for you in the kitchen area. I think it's December, so I think that's okay now. And for the people at home, I hope you have a nice lunch prepared as well. Thank you very much, and see you all soon.